Stephane Sizonenko and his team. Basically, we are honored to have you with us, great and dedicated NICU professionals, doctors, neonatal nurses here with us. And we know that we have a shared fact that not only we take care of newborn babies as a critical care provider point of view, rather we also support the baby to live their life with compassion and dignity for the future ahead. So I would like to welcome you again. A very good morning. I am Dr. Lokraj, Associate Professor Neonatal Division here. And after that, I would like to welcome you again, and I would like to request Professor Nisha K. Bhatta, HOD Pediatrics, Chair Neonatal Division, BPKIHS of Health Sciences, Stephane Sizonenko from Pediatric Department, faculties from Pediatric Department, Nursing Department in BPKIHS to come ahead for light lamping. Professor Nisha K. Bhatta, HOD and Chair Neonatal Division, Pediatrics Department, to express her welcome note on behalf of DC workshop program.
The Department of Pediatrics, BPKIHS, Dharan, has always worked towards promoting alignment and collaboration between stakeholders of the advancement and innovation in pediatric education globally. Our efforts are to connect national and international players active in neonatal and pediatric care, share and mobilize their expertise for fostering, streamlining, collaborative process. I would like to express my deepest appreciation to partners Geneva University in being partners in our journey. During my career as a clinician, teacher, researcher in the Academic Health Institute, in recent years, I have had the privilege of seeing myriads of ideas from inspired and passionate people trying to solve significant challenges related to healthcare of the newborn based around Nepalese health ecosystem, who has substantially contributed to collaboration, building local academic research leadership capacity and prioritizing long-term academic mentorship and relationship between University of Geneva and BPKIHS. We acknowledge and appreciate your commitment to improving developmental care practice in Nepal. We'll also like to acknowledge and welcome Mireille. She was there for the long time, Roxane, Valerie, for their contribution, and Caroline, for their contribution and support being here with us in this journey. Enriching day of learning and collaboration. Thank you for taking the time to support this workshop. There is emerging evidence that this care workshop involving anticipatory guidance and both intervention can improve social and emotional well-being, long-term neurodevelopmental outcomes in newborn. Enhanced caregiver-child interaction is associated with better confidence to manage their children, better knowledge of child developmental issue, a better home environment, and improved neurodevelopmental outcome. This workshop is designed to provide you with the knowledge and skill to enhance your understanding and application of developmental care principle. You have got an excellent lineup of resource person over the next 2 days, and I'm sure you are going to be stimulated and challenged by them. On the behalf of Department of Pediatrics, I commend all the resource persons for their collaborative effort. I'm grateful to the esteemed faculty, speaker, and each and every member of the organizing team, my department, and participant for being the part of the workshop. We are privileged to have in attendance of so many distinguished expert and resource persons and my department faculty as well as participants. I am confident that this workshop will give you the resource and skill to provide safe, stable, and nurturing and stimulating care to the newborn under your care, as we strongly believe that we must nurture a child by understanding their needs and responding sensitively to support their optimal brain growth. All children have a right to achieve their full neurodevelopmental potential and contribute constructively to the society. The component of this workshop will maximize the existing skills of the participant and develop core competence that will be crucial for the neurodevelopmental intervention. We are certainly, all of you will find this workshop stimulating, rewarding, meaningful, and we are excited to learn and grow together today. Welcoming you all once again and wish you all Happy New Year 2082. This New Year, may you achieve whatever you wish. Stay blessed with all this. Thank you very much.
I am Professor Rioual, Head Department of Child Health Nursing. Thank you so much.
And welcome on the stage, everyone. I'm Dr. Nisha, Head of the Department, Child Neonatal Division, BPKIHS.
So hello everybody. I'm Stephane Sizonenko, Professor at the Division of Child Growth and Development in the Geneva University Hospital.
I'm Mireille Rossi Jelidi. I'm nurse, training specialist in developmental care.
Everyone, I'm Professor Dr. Shah, working in the Department of Pediatrics and adolescent medicine. Thank you very much.
Dr. Stephane Sizonenko, Associate Professor, Department of Pediatrics. Thank you. I'm Dr. Dharan. I'm working as a Senior Resident, BPKIHS Dharan.
Minister, working as a Senior Resident in BPKIHS. Thank you.
Myself is Dharan, Deputy Resident, Nursing Institute.
Namaste everyone. Miku, Nursery, Senior Nursing Officer, Ward in charge, working in BPKIHS. Thank you.
Good morning and namaste to everyone. My name is Bhatta, Nursing Officer, working in Adolescent Nurse in BPKIHS.
Everyone, my name is Nisha K and I'm from Neonatal ward. Thank you.
Good morning everyone, myself Mailliez, working in Neonatal ward, BPKIHS. Thank you.
Good morning everyone, I am Sima Chaudhary, working as nursing staff with Neonatal ward, BPKIHS Dharan.
Namaste and good morning everyone. My name is Pooja Chaudhary. I am a nurse from BPKIHS in Dharan. I am working in the Neonatal department. Thank you.
I am Jamna Devi Urdel, working in BPKIHS in Pediatric department. I am Senior Nursing Officer. I am also DC nurse.
Clinical nurse specialist in Developmental Care in Geneva. I'm Caroline. I'm a nurse in PQ in Geneva.
Hello everyone, namaste. I'm Developmental Sizonenko, so Stephane's wife. And I'm also a pediatrician and geneticist and in charge of a rare disease center in Geneva.
Good morning everyone, I am Dr. Sumit Gimere, a pediatrician working at Jeevan Vikas Community Hospital, Katari Moran.
Hello everyone, myself Salini Mehta. At present I am working as a senior instructor in the Department of Child Health Nursing, BPKIHS. Thank you.
Namaste, I am Santi Ting from Child Health Nursing, College of Nursing. Thank you.
Namaste, myself Sridhar Singh, Rioual Medical College and Teaching Hospital. I am working as a nursing educator in pediatric department.
Good morning everyone. I am Asmita Gautam, NSU in charge from Nepal.
Good morning and namaste सबैजनालाई. म चाहिँ सुजना नमगर from Nepal Medical College as a staff nurse. Thank you.
Good morning everyone. I am Pratima Mandal from District Hospital, Sunsari, working as a staff nurse. Thank you.
मेरो नाम सकुन रसाइली. म पीडीडी डिपार्टमेन्टमा काम गर्छु as a senior staff nurse. Thank you.
Good morning and namaste to all. Myself Bina Limbu. I am a ward in charge of antenatal and labor room, and I previously worked as in NICU for 4 years. Thank you.
Good morning everyone. My self-introduction. Saraswati Shrestha. I am working in neonatal ward in charge.
Namaskar everyone. My name is Kalpana Sakhi, Gynae ward in charge.
Good morning, namaskar. म सकुन गुरुङ, pediatric ward in charge. Thank you.
Namaskar to all. I am Renuka Yadav, working in pediatric emergency ward in charge, senior nursing officer.
Good morning everyone. My name is Sujata Mokhtar and I'm working in labor room in the BPKIHS. Thank you.
Good morning everyone. My name is Anjani Balin as a nursing officer and mental labor room.
Good morning everyone. My name is Lila Biswakarma from labor room BPKIHS Dharan.
Me Sapna Dhunga from TUTS Kathmandu.
Good morning and namaste everyone. My name is Reena Desamaru. I am from TUTS working as a nurse in Neonatal.
Namaste everyone. I'm so glad to be here today. I am Dr. Nisha K. So BPKIHS is my alma mater and I always miss BPKIHS after going back. So I'm doing my DM neonatology. I'm pursuing it in the 3rd year of my residency and I am currently affiliated with Kathmandu University, Kathmandu Medical College. I'm here with my girl. Thank you.
I am Dipendra Rai, DM neonatal resident from Kathmandu Medical College, MBBS 2010 class from BPKIHS.
Namaste to everyone. I am Mireille Rossi from Kathmandu Medical College, working as a staff nurse since 14 years. Thank you.
My name is Resna Bania, working in Kathmandu Medical College.
Everyone, myself Madhuri Shah, currently studying MSc Nursing at BPKIHS Department of Child Health Nursing.
Good morning everyone. Myself Lakshmi Paudel, student of Child Health Nursing Department, MSc Nursing 1st year. Thank you.
Good morning everyone. Myself Robina Maharjan, MSc student, Child Health Nursing.
Namaste everyone. I am Ranjita Thapa from BPKIHS. I work in CLMC, Human Bank Milk.
Namaste, सबैजनालाई मेरो नाम मुना कसेल हो म चाहिँ एनएसयू डिपार्टमेन्ट BPKIHS
मेरो नाम निशा K हो म एनएसयूमा काम गर्छु.
Good morning everyone. I am Grishma Gautam, one of the registered nurses working in gynecological and obstetric theatre at BPKIHS Institute of Cancer.
My name is Sujata Rai, working as a registered nurse in gynecology. Thank you.
Namaskar, good morning. I am Suprema Mark, everyone.
My name is Arun Kumar Singh, working as an associate professor in pediatric department. Thank you very much.
Hello, good morning. I am Basant Rai, currently working as assistant professor in the Department of Pediatrics.
Good morning, myself Rosina Paudel. Currently working as a registered nurse in surgical ICU. Thank you.
To one and all present here, my name is Bhatta Shiva. I work as a nurse in an ICU department, BPKIHS.
नमस्कार सबैजनालाई म चाहिँ अमिता मगर हो म चाहिँ पेडियाट्रिक वार्डबाट
Good morning everyone, I am Elna Limbu, working as a nurse in pediatric department.
Good morning everyone, I am Dr. Neeraj Paudel, working as a junior resident in Department of Pediatrics.
Good morning everyone.
Myself, Lokraj, working as a staff nurse in NICU PICU department. Thank you.
Everyone, my name is Nisha K from NICU BPKIHS.
Good morning everyone. My name is Shah, working as a staff nurse in SS2 BPKIHS.
I am Mireille Rossi from MCS2, working as a staff nurse BPKIHS. Thank you.
Good morning everyone. I am Prof from MCS1 staff nurse. Thank you.
Good morning everyone. I am Muna Sharma from MCS department.
Conserve energy and enhance recovery, promote growth and the well-being, protect sleep, support the transition to the oral feeds to these fragile babies, and support emerging behavior at each stage of the neurodevelopmental maturation. Of the developmental care for the family, because it's a family center, that encourage the family and support the parents in their primary caregiver role, enhance the patient and well-being of the family. So what are the benefits that of the developmental care for the newborn? What we see is the improved short-term growth outcomes. It not only improves the short-term long growth, it decreases the length of stay so as to reduce the cost of stay, and it enhances to increase the breastfeeding rate at discharge, which is very important. And it has been seen that with the DC care, there is improved neuromotor developmental outcome at 24 months of the corrected age to this premature fragile newborn.
So, Ma'am has already discussed this part. So, if we see prior to 2016, our scenario was that we had a lack of structured developmental care program. We had challenges like our nurses, our doctors had very limited knowledge of DC care. There was no protocol. There was no protocol regarding the DC care. There was minimal parental involvement, because of which there was very high stress among the NICU parents of the NICU patients, as well as there was longer stays in NICUs. Also, there was increased rates of adverse outcomes. So, in the visionary leadership of our Professor Dr. Dharan and our very dear sir from Professor Dr. Stephane Sizonenko, this DC care workshop was initiated in the month of May. After that, from the year 2016 to 2023, there were several workshops annually. Except for the COVID years, we had annual workshops. Initially, it was limited to our own nursing staff. So, we definitely had a very wonderful hands-on sessions in the NICUs and nurseries. Subsequently, some of our faculties and some of our nurses visited the hospitals, universities that is in Geneva to have a look at the global standard of developmental care. The vitals, but apart from that, they started writing how is the sucking of the baby, how is the swallowing of the baby, how is the position of the baby, is the baby comfortable, has the mother visited the NICU or not. So all things were incorporated into our own nursing sheets. To further objectify it, to further give it an objective behavioral observational scale. And this we will be discussing in some of our sessions. And as ma'am has already discussed, 7 of our nurses were trained. They were accredited as DC nurses.
Would you please excuse my English? I will do my best. So, I'm happy to present today this team prepared for Madrid's Congress. I'm very thankful for the program. Baby have special needs. This has been scientifically proven again and again, and it makes it your duty to take special care of these children. I would like you to take a look at the brain's development. It's interesting to correlate this video with the degree That's why developmental supportive care for preventive care, knowing that every cause of stress and excessive stimulations can have deleterious effects on the brain's plasticity. It's also essential to guide the parents through the process of development of their premature baby. Let's talk about the sensory motor assessment created by Professor Boulanger. It's an important tool in my work, used during my consultation. It's a global child assessment which deals with its fragilities, its particularities, in order to adjust postural supports, cares, and its environment. Create a partnership where the parents. It shows them a different way of seeing their child, a better view of their child's competencies. You see, c'est juste, il y a quelque chose. Ça veut dire tout doux, Mireille. Tout doux. Tu vois la visite? Hein? Ouais. Bien. Moi, je vais copier tout ça et donner à tes parents. Hein? Ouais. Merci à toi. I'm going to show you the next video in the Development and Growth Division. Je suis sûre que vous mettez le bouton dessus. Vous voulez mettre le bouton? Oui, vous pouvez. Faites attention aux filles, puis vous allez l'appeler du côté. Je vais mettre. Ouais, bravo. Voilà. Donc c'est ça tout le travail de ce bras, de ramener dans son axe et qu'elle puisse attraper. C'est ça qu'on va faire. Parce que ça lui demande beaucoup de choses. C'est super. Tu vas bien aller. Voilà. C'est ça qu'on va pas faire Alors là, donc là, c'est vraiment ce côté-là qu'il faudra aussi travailler. Parce que vous voyez, il faudrait qu'elle fasse, bon, ok, qu'il y a ça qui la gêne, mais l'important, c'est de l'accompagner dans le dos. Déjà avec ce qu'on a, ça va changer. Je vais trouver un peu avec moi. Bon, regarde, tu vois, moi je suis là. J'ai bien travaillé, tu sais. Oh ouais, j'ai beaucoup travaillé. Si vous avez capté ça, ça vaut de l'or, plus que vous en voulez. And this is the second part of the clinical observation. Please take a look. I would like to show you now another video which is the result of the parents' involvement and all the in and out of hospital network.
The care and compassion and respect, dignity you give to the children, to the kids, and the testimony as it testifies very well, very nice. So with this we have a tea break downstairs. After half an hour of tea break, we'll have another sessions on proper DC care workshop in the form of position, orality, feeding, and SMS care. So after tea break, we have two important sessions which really deals with the topic what we are going to have in afternoon sessions, in as a practical sessions. Thank you. During practical sessions, so we will have 4 groups. Later, we will divide into groups, and the same thing. What we will deal here with in theory will be repeatedly be taught, learned, shared, and we receive guidance through our team, different nurses. So here I would like to invite our different nurses from BPKIHS who are well trained and who has been doing the same thing, repeating the same thing dedicatedly in NICU, nursery and neonatal ward. And I would like to invite different nurses to present on the topic positioning, orality and feeding. So I would like to invite our different nurses, Rioual to present a topic on positioning.
Well, we'd like to greet respected our department head, one of the powerful lady, none other than Nisha K Bhatta ma'am, who is not here. Likewise, I'd like to greet respected assistant professor, associate professor Dr. Lokraj from Switzerland, Professor Dr. Stephane Sizonenko, Professor Dr. Sizonenko, ma'am. Likewise, respected mentor, Mireille ma'am, Roxane ma'am, Kahui ma'am, who is also expertise in breastfeeding, our respected deputy matron ma'am, Tamang, nursing faculties, HOD, Professor Upendra Yadav sir, Professor Basanta Karna sir from Child Health Nursing, all the faculties, our in-charge ma'am, all the in-charge from different departments, our dear doctors, and all the participants here. Myself, Renuka Khadka, and my friends Silpa Shrestha, Marsana Limbu, Tija Rai, and Garima Khadka are here to present on the major elements, some cares, and in the end, feeling the grit, that is SM scale, sensory motor developmental care scale. What is developmental care? Developmental care is an art, the use of range of nursing interventions to decrease distance, including orality and feeding of sick newborns. So, without any delay, I'd like to hand over this floor to my friend Shilpa Shrestha, one of the referent nurse here, is going to present on the major elements of developmental care, which is positioning. Thank you.
Once again, good morning and namaste to everyone. म शिल्पा श्रेष्ठ आज हजुरहरूको माझमा डेभलपमेन्टल केयर अन्तर्गत सम इम्पोर्टेन्ट एलिमेन्ट्सहरू मध्येमा एउटा एलिमेन्ट्स लिएर आएकी छु। त्यो एलिमेन्ट्स भनेको पोजिसनिङ हो। हामीले पोजिसनिङ त हामीले काम गरिरहेको ठाउँमा अलवेज गर्ने गरेको छौँ हैन, सबैले गर्ने गरेकै छौँ। नट ओन्ली इन द वर्क्स, हाम्रो घरमा पनि हाम्रो बेबिजहरूसँग या हाम्रो ओल्ड एजहरूसँग हामीले पोजिसनिङ त गर्ने गरेकै छौँ। फेरि पनि यही टपिक लिएर किन आयौँ भन्दा, पोजिसनिङलाई लिएर किन आयौँ भन्दाखेरि डेभलपमेन्टल केयर अनुसार, डेभलपमेन्टल बेस्ड मोडल केयर अनुसार पोजिसनिङ कसरी गरिने भने त्यो सानो विषय लिएर फेरि पनि हामी आएका छौँ। कुकुनको ओपनिङ पार्ट चाहिँ बेबीहरूको पेल्भिक्सतिर हुनु पर्यो भने कुकुन बेबीहरूको हेड चाहिँ कुकुनको साइडतिर हुनु पर्यो। ओपनिङ पार्ट चाहिँ पेल्भिक्सतिर हुन्छ। त्यस पछाडि हामीले बेबीलाई चाहिँ स्लाइटली एसिमेट्रिकल ल्याटरल भएर बस्नु भएको हुँदैन। किन भन्दाखेरि हामीले बेबीलाई किन ल्याटरल राख्दैनौँ भन्दाखेरि ल्याटरल राख्दाखेरि जुन साइड बेबीको तलतिर हुन्छ त्यो साइड त ब्लक हुने भयो नि त आर्म्स त, बेबीहरूले अटो रेगुलेट गर्न सक्ने भएन। हामीलाई जस्तो अप्ठ्यारो पोजिसनमा बसेको छौँ भने हामीलाई सिधा आउनलाई केही कुरा गर्नुपर्छ, हामीले यो हातहरू हल्लाउनु पर्यो, आफूलाई सजिलो बनाउनलाई आफू जुन पोजिसनमा आउन सक्छ त्यो गर्नु पर्यो। त्यस्तै बेबीहरूले आफूलाई सजिलो बनाउनलाई अटो रेगुलेसन एक्टिभिटिजहरू गर्ने हुन्छ। दुईटा आर्म्सहरू फ्री हुन पर्यो, उहाँहरूले हात चलाउनु पर्यो, खुट्टा चलाउनु पर्यो। त्यही अटो रेगुलेसन एक्टिभिटिजले नै बेबीहरूले आफूलाई कन्ट्रोल र काम गर्ने गर्नुहुन्छ। र बेबीहरूलाई चाहिँ स्लाइटली राखेर जस्तै हामीले त्यो पिक्चरमा देख्न सक्छौँ लाई गरेको छ भने अर्को पार्ट अफ द कुकुनको साइडले चाहिँ बेबीहरूको सोल्जरलाई सपोर्ट गर्दै गरेको छ, त्यो माथि बेबीहरू हुनुहुन्न। सपोर्ट गर्दै गर्दै ओपनिङ पार्ट चाहिँ पेल्भिक्सतिर आएको छ। बेबीहरूको त्यो ओपनिङ पार्टको पेल्भिक्सले चाहिँ ओपनिङ पार्ट अफ द कुकुनले चाहिँ पेल्भिक्सलाई सपोर्ट गरेको छ। र अर्को हामी के गर्छौँ भने त्यति पोजिसनिङ गरिसकेपछि हाम्रो हस्पिटलको कुनै लिनेन होस् या बेबीको कुनै क्लोथ्स 1-2 आवर राखेर हामीलाई दिनुभयो भने त्यसले चाहिँ हामीले बेबीको पेल्भिक पार्टलाई कभर गर्ने गरेको छौँ। त्यो किन भन्दाखेरि बच्चाहरू आमाको वोम्थमा हुँदाखेरि कुनै पनि एउटा बााउन्ड्रिज एक्सटेन्सन गर्दा या के गर्दा बााउन्ड्रिज फिल गर्नुहुन्थ्यो नि त, जहीँ पनि इभन इन द ह्यान्ड, इभन इन द लेग बााउन्ड्रिज फिल गर्नुहुन्थ्यो नि त। त्यही बााउन्ड्रिज फिल गराउनको लागि चाहिँ हामीले कुनै एउटा पिस अफ हाम्रो हस्पिटलमा जे एभाइलेबल छ जे हामीले गर्ने गरेको छौँ, त्यसले पिस अफ क्लोथ या बेबीको पिस अफ क्लोथ या बेबीको पिस अफ क्लोथ मदरको ब्रेस्टमा 1-2 आवर राखेर हामीले त्यसले लिमिटेसन दिन सक्छौँ बेबीलाई। तर यति लिमिटेसन दिँदाखेरि चाहिँ हामीले के याद गर्नुपर्ने हुन्छ भन्दाखेरि त्यो पिस अफ क्लोथले बेबीको पेल्भिक पार्ट कभर गरेर हामीले कुसनतिर टक गर्दाखेरि चाहिँ के याद गर्नुपर्ने हुन्छ भन्दा बेबीलाई चाहिँ हामीले त्यो पिस अफ क्लोथले लिमिटेसन चाहिँ दिनु पर्यो, तर टक गरेर टाइट गरिदिनु चाहिँ भएन। किन भन्दाखेरि बेबीले आफूले आफूलाई कन्सोल गर्नुलाई, आफूलाई कम्फर्टेबल बनाउनलाई अटो रेगुलेसन एक्टिभिटिज गर्नुहुने हुन्छ। त्यो अटो रेगुलेसन एक्टिभिटिजमा त बेबीले आफ्नो खुट्टा चलाउनु पर्ने भयो नि त, त्यो चाहिँ हामीले ब्लक गरिदिनु भएन, त्यो चाहिँ हामीले याद गर्नुपर्ने हुन्छ। रोटेट गर्छौँ, त्यो रोटेट गर्ने प्रोसेसमा हामीले अलवेज बेबीको बडी एक्सेसलाई फलो गर्नुपर्ने हुन्छ। हामीलाई चित्त दुख्दाखेरि केही कुरा भन्छौँ, हामीलाई मन नपर्दा केही कुरा भन्छौँ, तर बेबीले एक्सप्रेस गर्ने कुरा भनेको के हो त? उहाँहरूको फेसियल एक्सप्रेसन, क्राईबाट र बडी एक्सेसबाट, त्यति नै त हो। अनि अलवेज डिसी केयर गर्दा डेभलपमेन्ट चाहिँ गर्न सिक्नुपर्छ। बेबीले फेसियल एक्सप्रेसनबाट के भन्न खोजिराख्नु भएको छ, बडी एक्सेसबाट के भन्न खोजिराख्नु भएको छ, त्यो चाहिँ हामीले अलवेज नै नोटिस गर्नुपर्ने हुन्छ बेबीको साइडमा जाँदाखेरि। जस्तै हामीले एसिमेट्रिकल साइडबाट प्रोन पोजिसनमा राख्दाखेरि बेबीलाई जेन्टली होल्ड गर्छौँ, होल्ड गरेर बेबीलाई जेन्टली रोटेट गर्दाखेरि यदि बेबी डिस्कम्फर्ट भइराख्नु भएको छ, डिसस्टिमुलेसन भइराख्नु भएको छ भने हामी त्यहीँ नै होल्ड हुने। बेबीलाई तुरुन्तै उसलाई अप्ठ्यारो भयो भनेर रोटेट गरिहाल्दैनौँ हामी। बेबीलाई त्यहीँ होल्ड गर्ने, कन्सोल गर्न खोज्ने, बेबीलाई काम गराउन खोज्ने। काम भइसकेपछि यु सुड अगेन हामीले प्रोसिड गर्न सक्छौँ हाम्रो प्रोसेसमा। सो जेन्टली बेबीलाई रोटेट गर्दै हामीले कुसनमा राख्छौँ। कुसनमा राख्दाखेरि कसरी राख्छौँ भने बेबीको वान साइड अफ द चिक चाहिँ एउटा कुसनमा लाइ गरेको हुन्छ र सोल्जर र एब्डोमिन चाहिँ त्यही कुसनमा लाइ गरेको हुन्छ अनि त्यति लाइ गरिसक्ने बित्तिकै बेबीको अटोमेटिकल्ली बेबीको दुईटा सोल्जर चाहिँ फरवर्ड हुने भयो दुईटा कुसनको बोथ साइड अफ द कुसनमा जाने भयो र फरवर्ड लिन हुने भयो प्रोनमा राखिसक्दा त यो पोजिसनमा हुन्छ नि त होइन बेबीहरू त इभन हामी पनि प्रोनमा हुँदा हात अभियसली हाम्रो अटोमेटिकली माथि जान्छ त्यति गरिसकेपछि यो छ हेर मैले त हामीले चाहिँ के याद गर्नुपर्ने हुन्छ भने हामीले चाहिँ बेबीलाई अलवेज जेन्टल टच स्लो मोसनमा बेबीको बडी एक्सेस फलो गर्दै नै जे पनि केयर गर्नुपर्ने हुन्छ सो यु क्यान सी फलो गरेर दिस स्टिमुलेसन भएको छ भने हामीले होल्ड गरेर उसलाई कन्ट्रोल गर्न खोजेर अनि प्रोन पोजिसनिङमा राखेका छौँ कुसन पनि हेर्न सक्नुभयो कुसन पनि यु सेपको कुसनलाई यहाँ ल्याएर सी सेपबाट राखेका छौँ यहाँ सी सेपमै छ बेबीको डिमान्ड के छ बेबीले के खोजिराख्नु भएको छ यदि उहाँलाई त्यो पोजिसनिङ गर्न मन परेको छैन भने यु सुड अलवेज स्टप बेबीले के मागिराख्नु भएको छ त्यही अनुसार चाहिँ हामीले केयर गर्नु पर्यो यदि बेबी डिसस्टिमुलेसन भएको छ बेबी डिसस्टिमुलेसन भइराख्नु भएको छ र उहाँले त्यो गर्न खोजिराख्नु भएको छैन भने अलवेज स्टप रेस्पेक्ट द डिसिजन अफ द बेबी बट स्टिल हजुरहरूलाई केही क्वाइरिज छ भने लाई ह्यान्ड ओभर गर्न चाहन्छु थ्याङ्क यू सो मच
तर पनि
हामी पढ्छौँ हामी लेख्छौँ हामी अघि बढ्छौँ ठुलो भई भोलि हामी देशलाई शृङ्गार्छौँ ला 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 ला
was suggested by my 5-year-old son. Well, our main aim of developmental care is Project Fisher Bolinga. Bolinga? Bulajia. साँच्चै नै भन्नुपर्दा हामीले यो गीतले भने जस्तै हामीले साना साना नानी बाबुहरूलाई भोलि गएर फ्युचर भनिन्छ नि भविष्यको कर्णधार भनेर हो भविष्यको एउटा कर्णधार फ्युचर वर्कर उनीहरूले नै हो देशलाई शृङ्गार्ने देशलाई हाँक्ने त्यसो तयार गर्नको लागि चाहिँ हामीले अहिलेदेखि नै भनौँ न यो जुन सबैको लागि बच्चाहरू प्रिसियस हुन्छ प्रिसियस बेबीहरूलाई साना साना बेबीहरूलाई चाहिँ केयर गरेर र सपोर्ट दिएर न्युरो डेभलपमेन्टल सपोर्ट दिएर उनीहरूको ग्रोथमा हेल्प गर्न हामी नै हो हामी शृङ्गार गर्ने उहाँहरूलाई शृङ्गार्ने हामीले नै हो उहाँहरू काँचो माटोलाई तयार गर्ने तयार भएको हुँदैन उहाँहरूलाई चाहिँ हामीले उहाँहरूको प्यासिभ फिडिङ उहाँहरूको जो ग्यास्ट्रिक फिडिङमा हुनुहुन्छ उहाँहरूलाई चाहिँ फिडिङको लागि तयार गर्नको लागि चाहिँ हामीले ओरल स्टिमुलेसन गर्ने गर्छौँ गर्न खोजिरहेको हुन्छौँ तर उहाँहरू इरिटेबल भइराख्नु भएको हुन्छ नजिएटेड भइराख्नु भएको हुन्छ अनि उहाँहरूको त्यो साइन अफ डिस्टिमुलेसनहरू हेरेर के चाहिँ गर्दा ठिक हुन्छ हामीले कुन टाइममा ओरल स्टिमुलेसन गर्दा ठिक हुन्छ भनेर चाहिँ हामीले त्यो हाम्रो उद्देश्य रहेको हुन्छ त्यस्तै मैले अघि नै भने जस्तै ओरालिटी डिफिकल्टिजहरूको भएको बेबीहरूको चाहिँ उहाँहरूलाई चाहिँ रिहाबिलिटेट गर्नको लागि चाहिँ यो मेन एम र अर्को मेन एम रहेको हुन्छ ओरल स्टिमुलेसनको र ओरल स्टिमुलेसन गर्दाखेरि चाहिँ हामीले एउटा सर्टेन पोइन्टमा गर्ने गरेका छौँ त्यो सर्टेन पोइन्टमा गर्दाखेरि हामीले चाहिँ म अहिले पछि पनि भन्छु र अहिले पनि अब भनिरहेको बेलामा भन्छु यो इयरको ट्र्यागसबाट यहाँ चिक्समा अलिकति जेन्टली प्रेस गरेर 5 to 7 सेकेन्डसम्म प्रेस गर्दै 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 यो इन अफ द कर्नर अफ द लिपसम्म गर्ने गरिन्छ भने त्यहाँ चाहिँ जस्तो हामीले किन भन्दाखेरि सलाइभरी ग्ल्यान्डहरू हुन्छ र सलाइभा प्रोडक्सनले चाहिँ बेबीलाई चाहिँ फिडिङको लागि स्टिमुलाइको काम गर्छ त्यही भएर हामीले यो ओरल स्टिमुलेसनको एउटा मेजर एम चाहिँ यो पनि रहेको छ सकिङ एन्ड swallowing पर्दछ भनेर Try to do oral stimulation before each feeding with baby's availability and needs. Baby ले चाहिँ कतिखेर फिडिङको लागि तयार छ बेबीको निड कतिखेर छ भन्ने चाहिँ हामीले बुझ्नुपर्ने हुन्छ र क्वाइट अवेकिङ स्टेट। हामीले चाहिँ डेभलपमेन्टल केयरको अर्को एउटा हाम्रो उद्देश्य चाहिँ के रहेको हुन्छ भने जहिले पनि हामी बेबीको स्लिप प्याटर्नलाई रेस्पेक्ट गर्ने गर्छौँ। बेबी क्वाइट अलर्ट र अवेकिङ स्टेटमा हुनुपर्छ हामीले यो ओरल स्टिमुलेसन गर्नको लागि पनि। त्यो स्मेलले उसलाई कस्तो स्टिमुलेट गराइरहेछ नि है। केही नबुझ्नु भएको छ? अहिले हामी ह्यान्ड एन्ड ह्यान्ड सेसनमा त गर्ने नै छौँ र केही यसका पनि की पोइन्ट्सहरू रहेका छन्। के रहेका छन् भन्दाखेरि हामीले चाहिँ जहिले पनि इट इज इम्पोर्टेन्ट टु अब्जर्भ एनी साइन्स अफ डिस्टिमुलेसन अफ द बेबी, मिमिक्स अफ डिसस्याटिस्फ्याक्सन, diversion, withdrawal, nauseous reflex, and to stop stimulation and wait until baby can accept the stimulation. मैले अघि नै भनिसकेँ, बेबीले कुनै पनि nauseous reflex देखायो, हामीले स्टिमुलेसन गर्दै गर्दा टर्निङ अवे द हेड गर्यो अथवा डाइभर्जन गर्यो, सेटिस्फाई छैन, फेसबाट पनि देखिन्छ नि त स्ट्रेस छ हैन, त्यो छ भने चाहिँ हामीले इमिडिएटली स्टप गर्ने ओरल स्टिमुलेसन। के गर्ने भनेर त अब हामीले अहिले पछि ह्यान्ड एन्ड ह्यान्ड सेसनमा देखाउँछ भनेदेखि अब हाम्रो इन द इन्ड केयर गरिसकेपछि चाहिँ केयर गरिसकेपछि हामीले एसएम स्केल सेन्सरी मोटर डेभलपमेन्टल केयर स्केल भर्ने गरेका छौँ र त्यो भर्नको लागि चाहिँ त्यो एउटा सर्टेन त्यसको पनि रुल्सहरू छ सर्टेन।
आई एम गोइङ टु कन्टिन्यू द प्रेजेन्टेसन अन अब्जर्भेसन अफ सेन्सरी मोटर बिहेभियर। यो चाहिँ यसलाई एसएम स्केल पनि भन्छ र यो एसएम स्केल भनेको चाहिँ के हो भन्दा the observation table of sensory motor behavior of newborn and it is based on the concept of sensory tonic balance and regulation. र यो यसको चाहिँ it is composed of 6 fields of observation. त्यसमा भनेको फर्स्टमा भनेको चाहिँ स्टेट अफ अलर्टनेस हुन्छ, अर्को भनेको चाहिँ फिजियोलोजिकल फिल्ड, अर्को भनेको चाहिँ पोजिसन एन्ड टोनस फिल्ड एन्ड अर्को भनेको टोनस इमोसनल फिल्ड एन्ड इन्टरेक्सन एन्ड नेक्स्ट सेन्सरी फिल्ड अनि नेक्स्ट भनेको चाहिँ ओरल स्फियर टेस्ट एन्ड अल्फ्याक्टरी स्टिमुलेसन। र यो सेन्सरी मोटर अब्जर्भेसन स्केलले चाहिँ यसले चाहिँ के गर्छ न्युरोलोजिकल इट इम्प्रुभ्स द न्युरो डेभलपमेन्ट अफ आउटकम अफ बेबी अल्टिमेटली। र यो स्केल भनेको चाहिँ एउटा यसले के डिफाइन गर्छ भने भेरिएबिलिटी अफ द बिहेभियर अफ द न्यूबोर्न, यो पनि एक्सप्लेन गर्छ। बच्चा बिचको एउटा बन्ड पनि इम्प्रुभ गर्छ र त्यसले गर्दाखेरि अल्टिमेटली सेन्सरी न्युरो मोटर एक्टिभिटिजहरू राम्रोसँग डेभलप गर्नलाई पनि हेल्प गर्छ र उनीहरूलाई कुनै हार्मफुल स्टिमुलेसनहरूबाट पनि हामीलाई छिटै त्योलाई रुल आउट गरेर पनि त्यसलाई इम्प्रुभ गर्न हेल्प गर्छ। र अब नेक्स्ट मुभिङ टुवर्ड्स मेरो फर्स्ट भनेको चाहिँ स्टेट अफ अलर्टनेस पोजिसनिङ गर्दा हरेक इच एन्ड एभ्री प्रोसिजर गर्दा चाहिँ हामीले यो स्केलमा भएको जस्ट हामीले यो स्केल फलो गर्नुपर्ने हुन्छ। र यसमा भनेको स्टेप हामीले बेबी रेडी कतिखेर हुन्छ त यो केयर प्रोभाइड गर्नको लागि भनेर हामीले एउटा गर्ने एसेसमेन्ट पनि हो। यो डिप स्लिप भनेर भन्ने चाहिँ एउटा फर्स्ट पोइन्ट भनेको चाहिँ अब डिप स्लिपमा हुँदाखेरि चाहिँ हामीले कहिले पनि बेबीलाई डिस्टर्ब गर्नु हुँदैन। अल्टिमेटली आवर मेन एम इज टु प्रोभाइड द इन्भाइरोमेन्ट टु प्रोभाइड प्रपर स्लिप टु द बेबी है। अनि स्लिप जति स्लिप उनीहरू मजाले सुत्न पायो, इन्भाइरोमेन्ट पायो, त्यति नै उनीहरू राम्रोसँग डेभलप पनि हुनसक्छ। त्यही भएर कहिले पनि हामीले यो प्रोसिडरहरू गर्नुभन्दा अगाडि चाहिँ बेबीको रेडिनेस एसेसमेन्ट गर्ने है यो अलर्टनेस भनेको चाहिँ। र डिप स्लिपमा हामीले बच्चालाई कहिले पनि प्रोसिडर गर्नु हुँदैन। गुड मर्निङ हुन्छ नि भनेर हामीले थोरै इन्टरेक्सन गरेर उसलाई चाहिँ केयरको लागि रेडी गर्न सकिन्छ है, इन्टरेक्सन गर्न सकिन्छ। र अर्को नेक्स्ट भनेको चाहिँ क्वाइट अलर्ट एन्ड वेकफुलनेस वर्डले नै एक्सप्लेन गरिरहेको छ। आइज चाहिँ वाइड ओपन हुन्छ लुकिङ फर द इन्टरेक्सन। जुन खेलिरहेको बच्चा हुन्छ न्युबोर्नहरू हामीले डे टु डे लाइफमा काम गर्दाखेरि अब्जर्भ गरिरहेको हुन्छौँ बच्चाहरू काम बेबी कस्तो हुन्छ उनीहरूले आइज वाइड ओपन हुन्छ लुकिङ फर द इन्टरेक्सन, हामीसँग बोल्न खोजे जस्तो गरिरहेको हुन्छ, एक्सप्रेसन दिइरहेको हुन्छ, पेज अटेन्सन टु नोइजेस। जस्तो हामीले साइडमा गएर उनीहरूलाई बोलाउँदा उनीहरूले हामीलाई हामीतिर फर्केर हेरिरहेको हुन्छ एन्ड मुभमेन्ट्स एराउन्ड इट, हामी जता गए त्यतै पनि उनीहरूको मुभमेन्ट देखाइरहेको हुन्छ। अनि उनीहरूको बोलीले मदरको भोइसले गर्दाखेरि बच्चा सुदिङ भएर काम हुन्छ है जहिले पनि। त्यो हामीले गरिराखेकोहरूले याद गरेको होला होइन। मदरलाई बोल्न टोनीको इमोसनल डोमेनमा चाहिँ सेल्फ रेगुलेसन एक्टिभिटिजहरू छ। अघि कुरा आएको थियो एकचोटि र यो भनेको भनेको चाहिँ के हो सेल्फ रेगुलेसन एक्टिभिटिज भनेको चाहिँ के हो भनेर भन्दाखेरि यो भनेको एउटा बेबी न्यू बर्न उनीहरूले आफूलाई डेभलप गर्नको लागि आफैले गर्ने एक्टिभिटिजहरू होला त्यसको त्यो भनेको चाहिँ द ह्यान्ड जोइन्ट द फिट टच ह्यान्ड जोइन्ट जहिले पनि बेबी यसरी पोजिसनमा बसेर चाहिँ ह्यान्ड टुवर्ड्स द चेस्ट लाग्ने हुन्छन् है युजली यसरी बस्ने हुन्छन् अनि त्यो ह्यान्ड्सहरू चाहिँ उनीहरूले टुवर्ड्स द माउथ लगेर अलिकति सकिङ जस्तो एक्सप्रेसन दिँदै हुन्छ र अर्को फिङ्गर सकिङ जस्तो अर्को चाहिँ ग्रास्पिङ हामीले आइभी लाइनहरू जोडेको हुन्छौँ एक्सटेन्सन लाइनहरू हुन्छ त्यो चाहिँ एकदम च्याप्प समातेर तान्न खोजिरहेको हुन्छन् त्यो भनेको पनि उनीहरूको एउटा अटो रेगुलेसन एक्टिभिटिज हो त्यस्तो एक्टिभिटिज देखायो एनजी लगाएको बेबीले एनजी तान्यो भनेर हामीले हातमा ग्लभ्स लगाइदिनु हुँदैन कहिले पनि हातलाई रिस्ट्रिङ गर्नु हुँदैन है त्यो किन भन्दाखेरि उनीहरूलाई अटो रेगुलेट गर्न सक्दैन है पोजिसनिङमा पनि कुरा आइसकेको छ हातहरू रिस्ट्रेन हुन दिनु हुँदैन र एनजी तान्यो एक घन्टैपछि एनजी तान्यो निकाल्छ भनेर त्यो हामीले हात चाहिँ बेबीले त्यस्तो गर्छ भनेर त्यो हातहरू रिस्ट्रेन गरिदिनु हुँदैन कहिले पनि किन भन्दा उसले त्यो फिङ्गर सकिङ ग्रास्पिङ भनेको उसको अटो रेगुलेसन हो यसलाई हामीले सपोर्ट गर्नुपर्छ र यो स्केलमा चाहिँ हामीले स्कोरिङ गर्दाखेरि चाहिँ 3 अर मोर देन 3 आयो भने चाहिँ यो प्रेजेन्टमा मान्छौँ नम्बर 1 स्कोरिङ दिन्छ र यो प्रेजेन्ट भएको चाहिँ राम्रो ल्याकिङ भएको नराम्रो है ल यति पार्टहरू र नेक्स्ट कन्टिन्यू गर्न चाहिँ एनी क्वेसन आई थिङ्क छैन जस्तो लाग्यो अब नेक्स्ट पार्ट कन्टिन्यू गर्न चाहिँ मैले हाम्रो मर्सना सिस्टरलाई इन्भाइट गर्दैछु
सिस्टर अब कन्टिन्यू विथ द टोनीको इमोसनल डोमेन मेरो भएको चाहिँ साइन अफ डिस्क्रिमिनेसन पढेको छ अहिले भर्खर हामीले सेल्फ रेगुलेसनको बारेमा पढ्यौँ जो चाहिँ हाम्रो बेबिज न्यू बर्नहरूको लागि चाहिँ न्युरो डेभलपमेन्टको लागि एकदम पोजिटिभ इम्प्याक्ट हो भने यो साइन अफ डिस्क्रिमिनेसन चाहिँ धेरैहरूले चाहिँ न्यू बर्नहरूको न्युरो डेभलपमेन्टको लागि चाहिँ एकदमै नेगेटिभ इम्प्याक्ट पार्छ भनेर हामीले सोच्यो साइन अफ डिस्क्रिमिनेसन चाहिँ मैले स्टार्ट गर्नेछु त्यो एकदम अब्जर्भ गर्नुपर्ने हुनेछ अब तपाईँले हाम्रो लिस्ट हेर्नु ट्रिमर भनेको हल्का आर्म्स लेग्स अनि बेबीहरूले चिनहरू सेक गर्छ नि जर्किङ मुभमेन्ट गरेको छ हामीले नोटिस गरेको छौँ होला त्यो आयो भने त्यो साइन अफ डिस्क्रिमिनेसन हो अनि यदि ऊ झस्किँदाखेरि बेबीहरूको आर्म्स एन्ड लेग्सहरूले जुनै पनि काम गर्दैछौँ जुनै पनि प्रोसिजर गर्दैछौँ हो त्यसलाई स्टप गरेर उसलाई सपोर्टिभ कन्टेनमेन्ट दिनुपर्छ त्यो चाहिँ हामीले ध्यानमा राख्नुपर्छ अनि अरू भनेको फिङ्गर्सहरू अनि लेग्सको टोजहरू प्यान्ट सेकमा आउँछ नि ऊ झस्किँदाखेरि हेर्नुभएको छ नि यस्तो भिजेर बसेको हुन्छ हो त्यो पनि साइन अफ डिस्क्रिमिनेसन हो अरू स्टार्टरहरू झस्किनु हिकअप्स गर्नु अघि भएर हामीले मिराई म्यामको भिडियोमा हेऱ्यौँ बच्चाले हिकअप्स गरिरहेको थियो स्निज गरिरहेको थियो रिपिटेटिभ स्निजिङ भयो भने त्यो पनि साइन अफ डिस्क्रिमिनेसन हो अनि अर्को यनिङ हामीले यनिङ गर्दा हिकअप्स गर्दा यसले यनिङ गर्दैछ भनेर त्यसरी छोड्ने होइन त्यो पनि एउटा साइन अफ डिस्क्रिमिनेसन हो उसलाई हामीले सेल्फ कन्टेन गर्नुपर्छ सपोर्टिभ केयर दिनुपर्छ है रिल्याक्स बेबी रिल्याक्स छ भनेर बुझ्छौँ होइन अनि यदि बेबी कन्टिन्यू क्राई गरिरहेछ हाइपर एक्सटेन्डेड मुभमेन्ट गरिरहेछ एक्सटेन्सन मुभमेन्ट गरिरहेछ भने अनि टर्की मुभमेन्ट गरिरहेछ भने चाहिँ त्यसलाई बेबी हामीले बेबी इरिटेबल भइरहेछ अनि इमिडिएटली जेसुकै गरेछौँ हामीले सबै स्टप गरेर सपोर्टिभ केयर दिनुपर्छ अनि यदि बेबी चाहिँ नो रियाक्सन नो मुभमेन्ट केही पनि मुभमेन्ट गरेको छैन भने चाहिँ त्यसलाई हामीले नो रियाक्सन भनेर माग गर्छौँ अब अर्को स्टिमुलेसन भनेको अडिटरी स्टिमुलेसन हामीले अडिटरी स्टिमुलेसन भनेको चाहिँ भोइस बच्चाहरूसँग अघि भने जस्तै कन्भर्सेसन गर्दै केयर सुरु गर्नुपर्छ उनीहरूसँग पर्मिसन दिनुपर्छ केयर गर्नुभन्दा अगाडि अब होइन गुड मर्निङ भनेर रिड गर्ने अब म तिमीलाई यस्तो गर्दैछु है भनेर कन्टिन्यू बोलेर यसको प्रोसिजरहरू स्टार्ट गर्ने चाहिँ प्रोसिजर स्टार्ट गर्दाखेरि अनि यदि अब हामी एकदम इन्भेसिभ प्रोसिजर गर्दैछौँ भने चाहिँ हामीले उहाँको प्यारेन्ट्सहरूलाई इन्क्लुड गरेर प्यारेन्ट्सलाई साइडमा बोल्नु लगाएर त्यो इन्भेसिभ प्रोसिजर गर्न सक्छौँ
उसको स्टेप कस्तो छ बेबी अलर्ट छ कि अवेक छ त्यो हेर्नै पर्ने हुन्छ यदि अब ऊ अगाडिको कुराहरू पनि इनपुट हुने हो जसले चाहिँ अब हामीलाई चाहिँ बेबीलाई हामीले चाहिँ कुनै पनि किसिमको डिस्क्रिमिनेसन नगरिकन उसलाई चाहिँ केयर दिने नै हाम्रो डिसी अन्तर्गतको यो इम्पोर्टेन्ट रोल हुन्छ होइन र हामीले चाहिँ बेबीको सुरुमा चाहिँ स्टेट अफ अलर्टनेस अगाडिकै कुरा भइहाल्यो त्यो हामीले एसिस्ट गर्नुपर्ने हुन्छ त्यसमा चाहिँ बेबी चाहिँ अब स्लाइड अब छ कि डिप स्लिपमा छ कि त्यो हामीले एसिस्ट गऱ्यो यदि ऊ चाहिँ स्लाइड स्लिपमा छ भने उसलाई चाहिँ हामीले चाहिँ अवेक गराएर अलिकति उसँग हामीले चाहिँ बोलेर कन्भर्सेसन गरेर हुन्छ कि उसलाई चाहिँ अवेक गराएर हामीले चाहिँ फिडिङको लागि रेडी गर्नुपर्ने हुन्छ र त्यसपछि हामीले चाहिँ मदर्स मिल्कमा डिप गरेको करणबाट चाहिँ इयरलोबबाट हामीले जुन यो स्टेप हामीले यो गरिरहेको हुन्छौँ त्यतिखेर चाहिँ हामीले चाहिँ बेबीको रेस्पोन्स हामीले हेर्नु पर्यो बेबीले के गरिरहेछ ऊ ओरिएन्टेड छ उसको लिप्सहरू मुभमेन्ट गर्यो या अथवा चाहिँ उसले चाहिँ टर्न अवे गर्यो के गरेको त्यो रेस्पोन्स चाहिँ हामीले चाहिँ एकदमै इम्पोर्टेन्ट छ त्यो एसेस गर्नुपर्ने हुन्छ र त्यही अनुसार चाहिँ हामीले चाहिँ फर्दर हामीले चाहिँ प्रोसिजर गर्नुपर्ने हुन्छ यदि ऊ चाहिँ बेबीले चाहिँ यदि स्टिमुलेसनको बेलामा चाहिँ ओरिएन्टेड भयो भने हामीले चाहिँ ट्विस्टको दिन सक्छौँ होइन यो चाहिँ पोजिटिभ रेस्पोन्स आयो र यदि चाहिँ बेबी चाहिँ रेडी छैन उसले चाहिँ अब टर्न अवे गर्यो फेस भने चाहिँ त्यो चाहिँ बेबी चाहिँ रेडी रहेन रहेछ भनेर बुझ्नुपर्ने हुन्छ र त्यति गर्दा हामीले त्यही 3 to 4 टाइमसम्म चाहिँ हामीले चाहिँ बेबीलाई चाहिँ स्टिमुलेसन गर्न सक्छौँ त्यहाँदेखि उता चाहिँ धेरै हामीले गर्नु मिल्दैन उसलाई चाहिँ त्यो चाहिँ फेरि डिस्टिमुलेसन हुन जान्छ त्यतिखेर चाहिँ हामीले 0 स्कोरिङ दिनुपर्ने हुन्छ है त्यस्तै गरी अब उसले चाहिँ अब स्टिमुलेसन देखायो भने चाहिँ रेडी रहेछ भनेर हामीले कन्टिन्यू हामीले चाहिँ त्यही प्रोसिजर वाइज चाहिँ हामी जानुपर्ने हुन्छ है त्यो सकिङ सर्निङहरू कस्तो छ त्यो हामीले एसेस गर्नु पर्यो र त्यही अनुसारले हामीले चाहिँ 3 2 1 0 अब रिपिटेड ट्राई गर्दाखेरि मात्रै उसले सकिङ गरेको छ या एकचोटिमै गरेको छ है त्यो अनुसारले हामीले हेर्नुपर्ने हुन्छ र यदि त्यस स्टिमुलेसनको बेलामा चाहिँ बेबी चाहिँ अलिकति हाइपर एक्सटेन्डेड भयो होइन नक्सियस डिप्रेसहरू भयो भने चाहिँ एकछिन होल्ड गर्ने र बेबीलाई चाहिँ हामीले चाहिँ एकछिन उसलाई चाहिँ हामीले अब क्लोज गर्दाखेरि होइन एकदमै हावा जर्नी गर्नु भएन ठुलो सामना खोल्नु भ्याङ्गे खोल्नु भएन होइन त्यो चाहिँ हामीले याद गर्नुपर्ने हुन्छ होइन जेन्ट्रीसँगले लोडहरू गर्नु पऱ्यो अनि भिजिटरहरूलाई चाहिँ अब जस्तै हाम्रो एनएसयू बाहिर चाहिँ अब अरूतिर के कस्तो छ हाम्रो एनएसयू बाहिर यहाँनिर चाहिँ अब बाहिर बेल राखिएको हुन्छ होइन अब त्यो बेल अब के सामानहरू लिएर आउँदा अब भिजिटरले के भन्नु छ भने बेल बजाइ रिपिटेड चाहिँ नबजाइले दिनु होला तपाईँहरूको बेबीहरूभित्र चाहिँ स्लिप अब सुतिरहेको हुन्छ होइन उनीहरू चाहिँ एक्कासी उनीहरू स्केयर हुने हामीले ह्यान्डओभर टाइममा भयो अब डक्टर्स राउन्डदेखि लिएर अब सिस्टरको ह्यान्डओभरहरू हुँदाखेरि पनि बेडको साइडमै गएर ठुलो स्वरूपमा हामीले ह्यान्डओभर टेकओभर गर्ने होइन बेडभन्दा थोरै अलिकति टेकओभर लिने गर्नुपर्दछ र राउन्डको समयमा पनि डक्टर्सहरूले त्यो कुरा ख्याल गर्नुपर्दछ त्यस्तै गरी अब हामी चेयरहरू यताउति साइडहरू चालेर गर्ने भोलि एकजनाले सकिँदैन गाह्रो हुन्छ भने दुईजनासम्म मिलेर होइन त्यसरी गर्नुपर्ने हुन्छ र कुनै पनि कुराहरू यताउति एनएसयूभित्र भएको कुनै पनि डस्टबिनदेखि लिएर अरू कुराहरू पनि यताउति हामीले सार्नु पर्दाखेरि चाहिँ एकदम जेन्टली ह्यान्डलिङ गर्नु पऱ्यो यो सबैले गर्दाखेरि चाहिँ बेबीलाई चाहिँ ह्याम्पर हुन्छ भन्ने कुरा बुझेर चाहिँ हामीले चाहिँ नोइजलाई चाहिँ सक्दो मिनिमाइज गर्नुपर्ने हुन्छ र त्यसै गरी अर्को रहेको छ लाइट अब बच्चाको लागि लाइट पनि एकदमै धेरै लाइट पनि एकदमै हार्मफुल हुन्छ है जसले चाहिँ गर्दाखेरि एकदम ब्राइट लाइट भयो भने पनि उसलाई चाहिँ भिजुअलमा चाहिँ स्ट्रेस हुन्छ होइन भिजुअल स्ट्रेस गर्दछ त्यसै गरी अब प्रिटर बेबीहरू अझ कति धेरै प्रिटर बेबीहरू हाम्रो एनएसयूमा हुन्छ होइन अब उनीहरूको त झन् आइलिडहरू चाहिँ होइन एकदमै थिन हुने अनि अब अगाडि नै अब उनीहरू प्रोग्रामहरू चाहिँ अगाडि नै अब उनीहरूको चाहिँ अब राम्रोसँग डेभलप नभइकन होइन उनीहरू चाहिँ अगाडि नै आउट भएको हुनाले गर्दाखेरि जसको उनीहरूको डेभलपमेन्ट राम्रो भइसकेको हुँदैन उनीहरूको कन्टेन्ट भेजेसहरू चाहिँ राम्रोसँग डेभलप नभएको कारणले गर्दाखेरि चाहिँ उनीहरूको चाहिँ लाइट होइन एकदमै धेरै लाइटसँग एकदमै सेन्सिटिभ हुन्छन् कि उनीहरू त्यही भएर चाहिँ यो लाइटको कुरा पनि हामीले याद गर्नुपर्ने हुन्छ
Would have been better with some images like how the baby has been destimulated, how it really looks like, how the signs of destimulations basically looks like. So this could have been added, but that basically we have left it for the hands-on hand session. So there we will show you pictures. We have some pictures, we have some hard copies, and in the session we will show you there. And here they have talked theoretical, how much we have imbibed, that is basically will be assessed in the sessions where we will do hands-on. And the next thing is all about development supported care through sensory motor approaches, about light, sound, and what is the amount of light basically we should be using, what is the sound, decibel, how we monitor sound, and how it is to be avoided has been talked, has been discussed by different nurses. But what is the actual level of decibel basically that is required for auditory development? What is the light? What is the lux of light that is required for their hands-on session? And there will be 4 groups. In the back on your that ID card, it has been designated Group A, Group B, Group C, and D. Accordingly, we'll arrange tables, 2 up here in this station, 2 outside in this corridor. So there will be 4 tables, 4 sessions, and after lunch will be. So you will be going to your designated tables, designated stations, and this is for registered participants. So all the registered participants are requested to attend their respective tables after having lunch. Thank you.
सो यसबाट निस्किनको लागि चाहिँ हामीले ह्यान्ड्स अन सेसन मात्रै छ अब होइन ह्यान्ड्स अन सेसन चाहिँ हामीले 4वटा ग्रुपमा डिभाइड गरेको छौँ ग्रुप ए बी सी डी तपाईँको आफ्नो आफ्नो आइडी कार्ड पछाडि तपाईँले हेर्न सक्नुहुन्छ तपाईँ कुन ग्रुपमा हुनुहुन्छ होइन अनि हाम्रो स्टेसन नम्बर ए र बी चाहिँ भित्र छ सी र डी चाहिँ बाहिर छ होइन तपाईँहरूले त्यही अनुसारले आफ्नो आफ्नो स्टेसनमा बैठ्नु होला अनि सानो एउटा अनाउन्समेन्ट छ कि हाम्रो एकजना एकदमै भाइब्रेन्ट डिसी नर्स हुनुहुन्छ टिचर सिस्टर हुनुहुन्छ उहाँको चाहिँ फोन मिसिङ छ कि अलिकति आफ्नो आफ्नो सिटिङ एरियामा एकचोटि हेरिदिनु न कसैले फोन देख्नुभयो भने इन्फर्म गर्नु होला आइफोन हो आइफोन हो एकचोटि हेरिदिनु होला है भेट्नु भयो भने
रिजन चाहिँ अब हामी 3 to 4 आवर्सको लागि हामी चाहिँ हेरिन्छ तर अब एज युनिट अनुसार हामीले बनाउनु गर्छौँ होइन अनि त्यतिखेर चाहिँ हामी के गर्ने भन्छ मदर छ भने सकेसम्म चाहिँ मदरलाई पनि हामीले चाहिँ राख्न सक्छौँ होइन मदरलाई पनि साइडमा राखेर चाहिँ दुईजना गएर चाहिँ गर्न सक्छौँ मदर छैन भने चाहिँ उयो आफै गरिसक्नुहुन्छ होइन उनीहरूसँग चाहिँ गर्ने होइन किनभने भने चाहिँ कहिले काउन्सिल गर्नुपर्ने हुन्छ होइन त्यतिखेरको लागि दुईवटा सुटिङ गराउनुको लागि चाहिँ दुईजनाको सपोर्ट चाहिन्छ हामीले जेन्टली ह्यान्डल गर्नुको लागि पनि है अनि अब बेबी होमले होइन अब हामीले भिसा दिनु पऱ्यो होइन अब जे पनि हामीले चाहिँ जेन्टली गर्नु पऱ्यो है यो ट्रिटमेन्ट गर्ने बेबी अलिकति चलिरहेको छ भने चाहिँ हामीले चाहिँ उसलाई चाहिँ अब यहाँ सुटिङ गराउने होइन अब हामीले हातमा कसरी चाहिँ अब चलिरहेको छ सबै कुरो चलिरहेको छ भने चाहिँ हामी चाहिँ मदरले यसो उसलाई चाहिँ कन्ट्रोल गराउनु पऱ्यो होइन कन्ट्रोल गराउने यसरी एक्सटेन्डेडहरू छ भने यो मदर चाहिँ यसो गरिदिनु पऱ्यो होइन अनि अब त्यसपछि अब यो ठिक छ बेबी अलिअलि चलिरहेको छ जोइन जस्तो भइरहेको छ उसलाई काम गराउनुको लागि हामीले चाहिँ मदरले चाहिँ यसरी हात होइन अब चेयरमा हात फेरि राख्ने योहरू गर्न सक्छौँ यदि यस्तो केही छैन भने चाहिँ हामीले होइन बिस्तारै हामीले स्लोली अब लिनु पर्ने यो गर्दाखेरि चाहिँ हामीले मेन भनेको चाहिँ अब सुरुमा डाइपर जुन हामीले रेडी गर्छ त्यतिखेर चाहिँ डाइपरलाई चाहिँ हामीले स्विच पनि गर्नुपर्छ त्यो कुरामा चाहिँ मैले ध्यान दिनु पऱ्यो है
इन्टरप्ट गरेर मैले यसरी कन्टिन्यू कमेन्टमा चाहिँ त्यो कुराहरू लेखिदिने ल अर्को फिजियोलोजिकल डोमेन गर्दाखेरि चाहिँ कार्डियो सर्कुलेटरी स्टेटमा चाहिँ अब बिफोर केयर के थियो नर्मल थियो होला मेबी स्लिपमा लाइट स्लिपमा हुँदा नर्मल हार्ट रेट थियो त्यसमा टिक लगाइदियो र ड्युरिङ केयर चाहिँ के भयो उसको हार्ट रेट हाई भयो किनकि ऊ एगिटेटेड क्राइम भयो भने एगिटेसन यो हार्ट रेट चाहिँ हाईमा लगाइदिने ल त्यस्तो जे छ त्यही त्यो हामीले प्र्याक्टिकली गरेर भन्ने होला यो बिफोर केयर भने ड्युरिङ केयर चाहिँ ड्युरिङ केयर रेस्पिरेटरी स्टेट पनि सेम होला त्यो रेस्पिरेसन कस्तो थियो बिफोर केयर ड्युरिङ केयर अनि अर्को भनेको चाहिँ टोनीको पोस्टरल डोमेनमा भनेको
गम्सतिरदेखि चाहिँ यतातिर बिस्तारै बक्कल मिल्छ अनि इनिसिएट गर्न सकिन्छ क्या अनि यो चाहिँ आउटर आस्पेक्ट आउटर भन्नाले यस्तो आउटर भन्नाले यस्तो पनि हुन्छ आउटर इनर दुइटै हुन्छ आउटर इनर दुइटै हुन्छ अनि यस्तो हुन्छ फेरि जस्तो अब हामीले यहाँ यति गर्दाखेरि पनि अब त्यसले चाहिँ हामीले जबरजस्ती अब त्यो विक सकिङ भएकोहरूलाई हो नि त अब यता पनि गर्ने बक्कलतिर पनि गर्नु पऱ्यो विक सकिङ भएकोहरूलाई चाहिँ फिडिङ डेभलप गर्नु स्ट्रङ सकिङ भएकोहरूले त अघि हामीले पनि भिगो सक्नु भने स्ट्रङ एन्ड भिगो त्यो छ भने त उसले चुसिहाल्छ हामीले केही इफोर्टै लाउनु परेन अनि हामीले अब फिडिङको लागि जस्ट उठाउँदा भयो उठाएर फिडिङ गरेर गराउनुको लागि रेडी गर्दा भयो
उहाँहरूले चाहिँ खुला नै पानी राख्नुहुन्छ अनि हामी त अलिक टाइट गर्नु भन्छ यो अहिलेको हाम्रो कन्सेप्ट चाहिँ डेभलपमेन्टल केयरको कन्सेप्ट चाहिँ कस्तो छ भने उनीहरूलाई त्यो पन्जा लगाइदिने मोजा लगाइदिने हुन्छ मोजा सुरुवाल त हुन्छ सुरुवाल मुनि मोजा भइसकेपछि उनीहरूले आफ्नो बडी कसरी फिल गर्यो त फिलै गर्न पाएन नि त अब उसको स्किन फिल गर्नु पाएन त्यो उसको फिट खाली भयो भने त उसको फिटलाई टच हुने भयो नि त उसले आफूले अटो रेगुलेट गर्न सक्नेको हातमा पन्जा लगाइदियो भने उसले यहाँ राखेर सुत्दा या यता कुनै छुँदा ग्राप्सिङ गर्दाखेरि उसले के फिल गर्यो त केही नै छैन नि त फिल गर्ने कुरा त त्यही भएर त्यो बााउन्ड्रिजहरू चाहिँ उनीहरूलाई छोडिदिने नलगाइदिने सेल्फ रेगुलेसन एक्टिभिटिजमा गर्छ
एनआइसीकै लागि नै हो कन्फ्युज नहुनु म चाहिँ त्यही भन्छु कन्फ्युज नहुनु होइन त्यो चाहिँ एनआइसीमै भएको बच्चाहरूलाई केयर गर्नको लागि हो क्या यो चाहिँ भनेपछि नर्सिङ गर्दाखेरि केयर गर्दाखेरि उताको तौरको भइहाल्छ नर्सिङ केयर गर्दाखेरि चाहिँ यस्तै खालको अब एनआइसीमा चाहिँ स्वाइडलिङ गरेर चाहिँ छैन नि होइन एसडिएम त ठिकै भयो जस्तै यहाँ कस्तो हुन्छ नि वार्ड भनेको चाहिँ पोस्ट नेटल वार्ड
पोस्टल वार्डमा चाहिँ गर्न सकिन्छ तपाईँसँग कुकुन छैन केही छैन बच्चामा त ब्ल्याङ्केट त छ नि त एडल्ट ब्ल्याङ्केट छ बेबीकै ब्ल्याङ्केट छ त्यही ब्ल्याङ्केटलाई तपाईँले यो रोटेट गरेर बनाउन सक्नुभयो
अहिले त ब्ल्याङ्केट पनि कुकुरवाला नै आएको रहेछ
आउँछ त्यो वाला बोट टाइपको बोट जस्तो नाउ जस्तो
यही ब्ल्याङ्केट होइन त यही ब्ल्याङ्केटलाई पनि त्यसरी राख्न सक्छ
ब्ल्याङ्केटले
ब्ल्याङ्केटहरू पनि सक्छ के त गर्न सक्छौँ उसमा पनि राख्न सकिन्छ वार्डहरूमा इभन मदर साइडमा पनि राख्न सकिन्छ त्यसरी यस पछाडि बच्चालाई हामीले पिकअप गरेर क्यारी गरेर रोटेट गर्दा अब यतिखेर एजिटेटेड हुनुभयो मान्नु भएन भने वी सुड अलवेज रेस्पेक्ट द डिसिजन अफ द बेबी जहिले पनि बच्चाले के गर्न खोजिराख्नु भएको छ के भन्न खोजिराख्नु भएको छ उहाँहरूले एक्सप्रेस गर्ने भनेको त यति र आफ्नो प्राइडको र हातको एक्टिभिटिजले त हो त्यो एक्टिभिटिजलाई बिस्तारै फलो गर्दै गर्दै वान साइडमा र यो चेस्ट र एब्डोमेन चाहिँ यो साइडमा लागिन्छ त्यस पछाडि बेबी यो साइडमा बस्नुभयो अनि यो त सिधा भयो नि त तपाईँले स्लाइटली टिल गरेपछि यो खुट्टा अटोमेटिकली यता आउँछ स्पोन्टेनियसली यता आउँछ र योले चाहिँ ब्याकलाई सपोर्ट गर्दै कभर गर्दै यसरी सपोर्ट गर्दा
हेरिरहेको हुन्छ कुनै बेबी चाहिँ होइन एक्टिभ नै भइरहेको हुन्छ नि त अनि गर्ने चाहिँ त्यही हो अनि ट्युब फिडिङ गर्दाखेरि पनि त्यो त यस्तो गर्ने कि अब हामीले पानी घट खायौँ भने कस्तो हुन्छ मम्मीहरूलाई नजेटेड हुन्छ नि हामी तर त्यही भएर फिडिङको चाहिँ जहिले पनि डिस्टेन्स मेन्टेन गर्ने क्या यति यहाँबाट ट्युब फिडिङ गराएको भन्दैमा अब यहाँ माथि नराख्ने हाई डिस्टेन्स मेन्टेन गर्ने स्लो फिडिङ गराउने यस्तो गर्ने बिस्तारै एजुकेसन चाहिँ कति बेला त्यो पनि फिडिङकै बेला त्यो पनि फिडिङकै बेलामा गर्ने अनि जब एनपिओमा छ भने पनि गर्न मिल्यो बेबीलाई यो स्टिमुलेसन चाहिँ हामीले फिडिङ प्रोग्रेस गर्नुपर्ने हुन्छ नि त अनि
मेन्टेनिङ डिस्टेन्स
why it's important to education मैले यो भनिसकेँ नि यो
white sound should not come out. Sound should not come out. Noise should not be there.
Yeah.
Okay. If the baby is moving like
yes.
तिमीले त सुनिसकेको छ हिजो अस्ति भर्खर इरिटेटिङ हुन्छ क्या पुरै यो इरिटेटिङ अब उनीहरूको त अब त्यो अरू उनीहरूलाई त झन् धेरै हुन्छ नि त त्यही भएर स्लो जे गर्दा पनि त्यही कुराहरू हो तपाईँ जस्तै रिल्याक्स भयो त्यो हामीले रुमलाई छोड्दै भयो उसको न्युरोलोजिकल असर गर्छ क्या है त्यही भएर अलिकति
यो भर्ना चाहिँ तपाईँलाई यो चाहिँ कति टाइम लाग्छ
यो भन्न त अब बिफोर केयर त हामी बिफोर केयर भइहाल्यो आफ्टर 10 मिनट्स यो चाहिँ टाइम अब फेरि यस्तो हो नि लेन्थ अफ केयर भनेको केयर गरेको भयो कति बेला भयो यहाँ हाम्रो टाइम लिमिट छ क्या दिदी त्यही भएर भिडियो पहिला भिडियो देखाउँ कि अनि यो भोलि तर्का सिकाइदिनु पहिला भिडियो देखाउँछौँ न थ्योरिटिकल क्लास भइसकेको छ है यो स्केलमा हामीले भनिसकेको छौँ धेरै कुराहरू त्यो कुराहरू लिङ्क गर्नको लागि चाहिँ यहाँ सर्टेन भिडियोहरू छ कि त्यो भिडियोहरू देखाउन जान्छौँ न हामी सुरुमा चाहिँ स्टेट अफ अलर्टनेसको भिडियो छ यो यसमा यता पट्टिबाट आउनु यो छ मैले के भनेको डिप स्लिपमा आई मुभमेन्ट हुँदैन ह्यान्डहरू मुभमेन्ट हुँदैन त्यस नर्मली डिप स्लिप भनेको चाहिँ हाम्रो अहिले के हो लाइट स्लिपमा गयो है म चाहिँ आफै लाइट स्लिपमा गएँ नि स्लिप साइकल पुरा गर्छु अनि त्यसमा एगिटेसन गयो एगिटेसन एन्ड क्राइङमा गयो है बुझ्नु नि सबै एउटै कुरा भयो स्लिप भइहाल्छ कि अब एगिटेसन एन्ड क्राइङमा गयो अब हामीले यसमा चाहिँ यो सायद भिडियो बनाउँदाखेरि के पनि केयर दिनु भएको छैन नत्र भने यस्तोमा हामीले यतिकै छोड्नु मिलेन बच्चालाई सुटिङ गर्नु पऱ्यो अनि टच हामीले हेडमा र के भन्यो डाइपरमा चाहिँ
बोक्नु सक्नुहुन्छ क्या जस्तै होइन यसरी होइन मजाले पनि यसरी बोक्नु सक्नुहुन्छ त्यो भयो भने अप्ठ्यारो भयो भने है उसलाई उचाल्नुको साथै चाहिँ हामीले यसो गर्न सक्छौँ मजालाई चाहिँ यहाँनिर हात राख्न पनि लिन सकिन्छ है त अनि त्यसपछि यस्तो छ अब अहिले चाहिँ म त एक्लै त होइन मैले अहिले गरिरहेको छु बेबी चाहिँ कामै छ भनेर बुझ्नु पऱ्यो कामै होइन यस्तै छ धेरै मैले उचालेको छुइनँ होइन टाइपहरू उसले चाहिँ होइन छोड्दै नछोड्ने एउटा कतै न कतै उसलाई त टच त दिनु पऱ्यो नि त होइन सेफ्टी त गराउनु पऱ्यो अनि हामी चाहिँ यो लाउँछौँ यो लाउँदाखेरि चाहिँ अमेरिकालाई चाहिँ कभर गर्नु भएन होइन इन्फेक्सन हुने चान्स हुन्छ त्यही भएर अमेरिका कभर नगरी कभर राख्नुपर्ने हुन्छ अनि कहिले कहिले चाहिँ के हुन्छ अब सधैँभरि हामी देख्दैन हुँदैन उसलाई कभर गराउनु हुँदैन कपडा हो त्यस्तो हामीसँग कहिलेलाई कभर गर्ने कपडा हुन्छ त्यो कपडाले चाहिँ होइन यसो कभर गर्ने होइन यो यसो हात चाहिँ छोडिदिनु भएन यसो गरेपछि ऊ चल्छ ओर्छ नि त चल्दा ओर्दा उसले आफैले यो यहाँ कपडा राखेपछि त अब यता ल्याउँदैन माउतिर उसको ह्यान्डहरू लाने गर्ने होइन सेल्फ रेगुलेसनहरू चाहिँ उसले गरिरहेको हुन्छ कि अब त्यो पनि उसलाई चाहिँ अब यो उसलाई हामीले बााउन्ड्री केयर गरेकै सम्झिनु पर्ने हुन्छ होइन अब एक्लै हुँदाखेरि त्यसो गर्नु सक्छ त्यो भएपछि चाहिँ यहाँनिर यसो लगाइदिएपछि यो अलिकति यतातिर ल्याउने चान्स पनि हुँदैन है यो चाहिँ एक्लै सबै छुँदाखेरि चाहिँ यो गर्नु सकिन्छ है त
होम बेस्ड हो हस्पिटलमा चाहिँ डाइपर
हस्पिटलमा चाहिँ कपडा चाहिँ युज गर्नु भएन
म्यानपावरले पनि पोसिबल हुँदैन सुतीको त अलिकति अब
अनि अब म सोधिहाल्नु ल कतिको रिलेटेड हो जस्तो डाइपर है अब त्यो चाहिँ कतिको के छ केही आइडिया छ त्यसको बारेमा कन्टिन्युस डाइपर लङ टर्म जस्तो अब 1 वर्ष 2 वर्षसम्म बच्चाहरूलाई युज गर्यो भने त्यो ग्रोथ हुँदै नै बोनहरू एकदम लेगहरू फार हुने त्यस्तो त्यस्तो सुनेको अब कतिको
त्यो चाहिँ हामीलाई थाहा भएन तर मलाई चाहिँ के लाग्छ भने म आफैले सोच्दाखेरि सायद पहिले चाहिँ हामीले ठ्याम्मै नै यसरी लाउँथ्यो नि त ठ्याक्कै लाउँथ्यो यसरी चाहिँ त्यो स्विचहरू गर्दैन थियो त्यसले गर्दा अप्ठ्यारो हुन्थ्यो होला नि त उसलाई मलाई लागेको चाहिँ तर त्यो
लङ स्टेप बस्यो भने
स्क्विज गरेर लगाएपछि जेउको खुट्टाहरू जोडेको यस्तो चाहिँ अब अलिक कडावाला छ अनि हामीले स्क्विज नगरिकन लाँदाखेरि त्यतिखेरै थाहा पाइन्छ क्या उनीहरूलाई त्यस्तै नै हुन्छ त्यही भएर स्क्विज गरेर
हामीलाई होइन अनि अर्को कुरा भनेको चाहिँ त्यो अब इरिटेसन डाइपराइसिस भनेको त्यो त अब प्रोलङ टाइमसम्म अब युज गरिरहेछ चेन्ज गरेर त्यो पनि हुने हो नि
नेपालको सिनारीमा चाहिँ नर्स पेसेन्टले चाहिँ मिलेको छैन तर अब हामीले जहिले पनि हेल्थ चेकअपलाई आफ्नो 2 hands र प्यारेन्ट्सको 2 hands चाहिँ हुनै पर्यो है केयर गर्दाखेरि हैन अनि अथवा विथ कलिग्स अब यदि इनफ स्टाफ भएको सिनारियो छ भने चाहिँ विथ कलिग्स पनि गर्न सकिन्छ एलोन पनि अप्सन राखेको छ उहाँहरूले अनि तर प्रायः चाहिँ प्यारेन्ट्सहरूसँगै मागेर गर्नु अनि राइट साइडमा अर्को भनेको लेन्थ अफ केयर छ कति मिनट्स लाग्यो जस्तो 20 मिनट्स 25 मिनट्स अब के हो केयर अनुसार डिपेन्ड हुन्छ होइन अहिले हामीसँग केयर गर्न लागि छैन भोलि चाहिँ अब हामी त्यो अर्को भनेको चाहिँ अब यो भन्ने सिस्टम तरिका भनेको चाहिँ बिफोर र ड्युरिङ केयर भनेर छ यतापट्टि एक्सप्रेसनहरू पुरानै कुराहरू भयो अघि पढाएकै अब मेन हामीले फोकस भनेको चाहिँ रेटिङ स्केल अनुसारले बिफोर ड्युरिङ केयर भयो है यहाँ सबै ओपन छ कि ब्याकेट छ तल गएर एउटा चाहिँ सेडेड पार्ट छ नि सेडेड पार्ट भएको ठाउँमा चाहिँ हामी नभने यो वाला चाहिँ हाम्रो ड्युरिङ केयरलाई मात्रै भनिन्छ ल हेरिराख्नु भएको छ अब फर्स्टमा चाहिँ अब डिप स्टेट अफ अलर्टेसन डिप स्लिपमा छ भने त हामीले केयर नगर्ने भनेर मैले अघि भन्छ कि वेट गर्ने वी क्यान वेट नगर्ने मतलब हामीले त्यतिखेर चाहिँ स्किप गर्ने वेट गर्ने उसको स्लिप साइकल पुरा भएपछि लाइट स्लिपमा गएपछि चाहिँ हामीले बच्चालाई के गर्ने अलिकति सुत्यो अब हामीले आफ्नो भोइस अडिटरी उस गरेर गुड मर्निङ भन्ने अलिकति लाइट स्लिपमा भएको बच्चाहरू चाहिँ अलिकति क्वाइट अलर्ट स्टेजमा आइहाल्छ है नत्र आफू पनि आउँछ त्यो अनुसार बिफोर केयर के थियो बच्चा डिप स्लिपमा थियो भने त भइहाल्यो कमेन्ट्समा के लेखिदिनु बेबी वाज इन डिप स्लिप सो स्किप हामीले चाहिँ अलिक वेट गऱ्यौँ भनेर लेखिदिने लाइट स्लिपमा थियो भने लाइट स्लिपमा थियो मैले यसरी भयो के अरे भोकल उयो गरेर बच्चालाई चाहिँ बच्चा क्वाइट अलर्ट भयो त्यस पछाडि मैले केयर सुरु गरेँ भनेर लेखिदिने होइन
तपाईँले अनि अर्को भनेको चाहिँ बेबीको हामीले मदर मिल्क स्मेल गराउँछौँ भने नि एम्नियोटिक फ्लुइड र मदरको मिल्कको चाहिँ सेम स्मेल हुँदो रहेछ कि त्यसले गर्दाखेरि चाहिँ उसलाई चाहिँ अब आफ्नो आमासँगै नै छ आफ्नो आमा वरिपरि नै छ भन्ने खालको हुँदो रहेछ सब त्यो आमाको पेटमा भइरहेको हुन्छ नि त त्यही इन्भाइरोमेन्ट नै क्रिएट गर्न खोजेको हामीले
अर्को चाहिँ त्यो कोलेस्ट्रोल या मिल्क नै कटनमा या कुनै कपडामा भयो मुनि पनि राख्दा पनि भयो होइन आमाकै लुगा ल्याएर राख्दा पनि भयो
जस्तो बच्चाको फिडिङ टाइम हुने बेला भयो फिडिङ टाइम भयो अब होइन तपाईँ बच्चाको बेड साइडमा जानुभयो बच्चा डिप स्लिपमा छ लाइट स्लिपमा छैन भने यु क्यान स्किप किनभने उसलाई भोक लागेको छैन नि त उसलाई त्यो टाइम हामीले स्किप गर्न सक्यौँ उसको लागि किनभने उसको त त्यो न्युरो डेभलपमेन्ट भइरहेको टाइम हो नि त सो एकछिन स्किप गरिदिँदा भयो त्यस पछाडि फेरि एकछिनपछि गएर हेरेर अब्जर्भ गर्दाखेरि ऊ यदि लाइट स्लिपमा छ भने उसलाई अवेक गर्न कोसिस गर्ने भयो अब निद्रा पुग्यो अब उठ नि त अब खाने बेला भयो त तिम्रो खाने बेला भयो त त्यति गर्दाखेरि ऊ अवेक हुन्छ भने उसलाई फिड गराउन पाइयो त्यतिखेर अवेक भयो भने चाहिँ फेरि ऊ त्यति गर्दा गर्दै पनि स्कुलमा गयो उसलाई भोक लागेको छैन सानो बेलामा
उसले एक्सपिरियन्स पनि गर्छ दुईवटा एउटा ड्यापर उसले
we those babies will start with the almost full feeding, rapid feeding. Is also hello.
फिडिङ गर्नु भयो एनएसी हुन्छ त्यो भएर फिडिङ पनि टाइमली नै सुरु गर्नु पऱ्यो एनएसी डिले गर्दा पनि हुन्छ एकैचोटि प्रोग्रेस धेरै
Even cesarean को within hourमा 1 hourमा there is a breastfeeding.
प्राइभेटमा त एकदम बर्बाद छ
प्राइभेट
होइन इभन मेडिकल कलेजले पनि त एटलिस्ट
मेडिकल कलेज पनि त
सिकाउने विद्यार्थीले सिकाउने हो नि त त्यहाँ त प्राइभेट भयो भने त सिक्ने त त्यही सिक्छ नि त कतिजनासँग मेरो डिस्कस पनि परिसकेको छ यसको लागि
पोलिसी नै बनाएको छ एटलिस्ट 24 आवर चाहिँ
पोलिसी नै हो त्यो इजी अप्सन भयो क्या भावना सुरु हुन्छ अनि त्यसपछि आमाको माया हुँदैन
तताएर अथवा रब गरेर अलिकति टेम्परेचर मेन्टेन गरेर उसलाई त्यो कति त्यो हामीले बेस जाँदा पनि तसङ्ग भएर उठिरहेको हुन्छ किनभने चिसो हुन्छ नि त त्यस्तो कुराहरू गर्ने सिचुएसन पुगिसक्छ क्या त्यो कुराहरू चाहिँ याद गर्नु पर्छ अब छेउमा केही कपडा छ भने त्यो कपडा बाँकीबाट पनि हामीले सुनिन्छ नि त त्यो सुनेर है त्यो सुन्ने हाल्टो त भइहाल्यो टेम्परेचर जाँदा पनि हामीले एकदम सफ्ट ह्यान्डले सबै कुरा गरेपछि ऊ स्टुडेन्ट हुँदैन क्या त्यस्तो त्यो चाहिँ गर्नुपर्छ जुन केलाई पनि मैले भाइको सानो इक्जाम्पल दिएँ अरू कुरामा पनि त्यस्तो गर्नुपर्छ
And not okay. Because the baby needs contact.
सपोर्टिभ केयर दिनको लागि राम्रो हुन्छ। अब दुईजना नहुनु खण्डमा चाहिँ हामीले के गर्छौँ भन्दा चाहिँ यही कपडालाई चाहिँ यो अहिले एकजनाको उसमा भनिहाल्छ है सन्दर्भमा एकजनामा यो छ भने चाहिँ यो हामीले चाहिँ बेबीलाई चाहिँ अब यो कभरले नै कपडाले चाहिँ कभर गर्न सक्छ क्या त्यो भएपछि उसले हातहरू धेरै यताउति चलाएर अलिकति अब भयो नि त एकजनामा चाहिँ अब दुईजना छौँ भने चाहिँ अब हामीले के गर्नु भने माथि अब यसो गर्नु गइरहेको छु भने होइन पनि होइन बिस्तारै चाहिँ डिसिसन छ त्यो चाहिँ पनि अब स्लोली जेन्टली नै भनेको होइन गर्नु गर्नु पऱ्यो होइन अब त्यसमा चाहिँ अब अब उसलाई कपडा हटाइदियो अलिक समर जस्तो भयो अरू भने मजाले तपाईँहरूले चाहिँ राख्ने होइन कन्सेप्ट चलिरहेछ स्विमिङ गर्नु खोज्यो भने यसो होइन उहाँले काम गराउने होइन बोल्दाखेरि पनि दुईजना चाहिँ बोल्नु भएन दुईजना भयो भने कताबाट बोल्नु भने उसलाई चाहिँ कन्फ्युजन हुन्छ होइन अब एकैजनाले चाहिँ मजा छ भने त मजा नै बोलेको बेस्ट हुन्छ होइन कताबाट गफाउने बोल्ने उसलाई कन्फ्युज गर्दैन त्यसरी अब हामी चाहिँ एकजना छौँ है अब त्यस्तो गर्ने चाहिँ हामी खोल्यो होइन
नर्मल रेन्जमा छ नि त होइन त्यो देखाउनु खोज्छु ल नर्मल सबै कुरा नर्मल छ उसको पोजिसनमा बेबीको यो के छ बेबीको कर्ल पोजिसन कर्लमा छ ह्यान्ड्स टुवर्ड्स द चेस्ट फेसमा भइहाल्यो फिट टच भइहाल्यो है त्यो प्रपर पोजिसन यो नर्मल पोजिसन भयो बेबीको ल अहिले टेन्सन गयो हाइपर टेन्सनमा चाहिँ हाइपर के भयो ब्याक पेन छ होइन अनि त्यस पछाडि यो
अस्ति हामीलाई भरे चाहिँ सिकाउनु भएको थियो Handle पनि properly handle गर्नु पर्यो. A good installation is the first part of all. Okay? You can put your hand. Yeah. And a little asymmetric position.
बोल्दै पनि जाने.
It will be good. And now you can.
बोल्दै जानुपर्छ क्या अनि आफूलाई पनि टाइम हुन्छ उसलाई पनि रमाइलो हुन्छ नि त.
It's important to make a pressure. Put it like this and slowly.
टच लगाएर उनीहरूलाई थाहै हुँदैन नि टच त गर्नै पर्छ.
Not slowly, but with the pressure. I'll show you why. Because if you make it like this, it's not a clear information. If you make like this, it's more clear. You know?
टच त हुनै पर्छ.
Can I? Yes.
केसेसहरूमै सुरु भइसकेको हुन्छ नि त अब त्यसमा त्यसो हुनाले चाहिँ अब बेबी जन्मिसकेपछि पनि अब सिक बेबीहरूलाई चाहिँ नत्र अरू बेबीहरू किन्नेपेक्षा आफै त्यो डेभलप भइसकेको हुन्छ केही गर्नै परेन होइन अनि त्यसपछि आफै त्यो हामीले चाहिँ भनेको हामीले मान्छेलाई त भन्छु नि तपाईँलाई क्यामेरा लाउनु लाग्ने
रेस्पोन्स गर्छ यो मेरो यसमा त केही हुँदैछ है भन्ने
अहिले पेनमेन्ट पुऱ्याउने हो
अनि अब हामीसँग अभाइलेबल छैन तर हामी टेक्स्टहरू सक्छौँ तर पछि चाहिँ स्कुल स्पेसिफाई नभए पनि स्कुलको केही हुन्छ नि त्यो पाउँछ अरे त्यो भयो
स्पेसिफाई हो
हाइजेनिक भनेर एनसी होला होइन त्योहरू पनि हुन्छ अनि
फर्दर कम्प्लिकेसन आउँछ
स्पेसिफाई मदर भन्नाले यतिकै एसएस गरेन त्यो त हेल्दी प्र्याक्टिस भएन त्यही सोधिराख्नु भएको थियो अस्ति यहाँनिर प्यासे योभित्र के हुन्छ भनेर भन्नु मटेरियल किन हामीले यो चाहिँ यो स्क्विजले हुँदाखेरि हुँदैन नि त तर त्यो अब कसरी भयो त्यो त किन कसैले पाल पारिदिनुपर्छ होइन कि त विक खालको हुनुपर्छ न तपाईँको त्यसरी त त्यो नहुनुपर्ने नि त लिकेज त नहुनुपर्ने हो नि त यहाँ बिहान दिनुहुन्छ कि हाइजिन मेन्टेन भएन भने फेरि अर्को प्रब्लम आउँछ भने झर्छ नि त त्यो यस्तो अनि त्यस्तोहरू पनि नगर्ने यस्तो यस्तो पनि नगर्ने राख्ने छ भने अब मदरहरूले पनि गर्नुहुन्छ नि बेबी रोइरहेछ भने गर्ने गर्नुहुन्छ नि त्यस्तो होइन क्या यस्तो यस्तो राखिरहने कस्तो गर्ने राख्नु होइन यस्तै राख्नु बेबी भनेर आई टु आई कन्ट्याक्ट हुन्छ बोल्छ भन्नाले अब कन्भर्सेसन क्या आई थ्रो आइस अब त्यो कुनै पनि साइन अफ स्ट्रेसहरू छ भने त बेबीले यस्तो गरिरहेको हुन्छ होइन आइजहरू अब त्यो एसएम स्केलमा पनि को गएर आउनु होइन एसएम स्केलमा पनि थाहा हुन्छ नि त प्यानिक हुन्छ होइन अनि त्यो के भन्छ फ्रोजन फेस देखाउँछ त्यस्तो त्यस्तो हुन्छ त्यही भएर चाहिँ अब हामीले बेबीको चाहिँ त्यो क्वाइट अलर्ट अवेकनिङ स्टेट चाहिँ ध्यान दिनु पऱ्यो सबभन्दा बेस्ट टाइम भनेको त्यही हो
मेन हामीले फेसलाई चाहिँ रिड गर्न सक्नु पऱ्यो क्या
एक्सप्रेसनलाई उनीहरू त बोल्न सक्दैन नि त हामी उनीहरूको भाषा बुझ्ने भनेको उनीहरूले के गरिरहेछ ल्याङ्ग्वेज बुझ्ने हामी त कति है सुपेरियर क्या न्युनेटलको भाषा बुझ्ने भनेको त होइन न्युनेट्सहरूको अनि मदरले चाहिँ कन्सल्ट गर्छ मदर अभाइलेबल हुनुहुन्छ एउटा हातले ग्रास्प गर्न
Now I can make feeding stimulation.
कहिले पनि छोइसकेपछि झ्याप्पै एकैचोटि नछोड्नु छोड्दाखेरि त्यो फेरि साइन्स अफ दिस स्टिमुलेसन हुने हुन्छ त्यही भयो मदर फादर जो हुनुहुन्छ एभाइलेबल उहाँलाई लिन सकिन्छ या त हाम्रो हेल्पिङ ह्यान्डहरू दिदी दाईहरू हुनुहुन्छ लिन सकिन्छ अनि हामीले कन्सोल गर्ने मान्छेले चाहिँ जहिले पनि एउटा हात हेडमा राखेर कन्सोल गर्ने र एउटा हात चाहिँ बटक्समा राख्ने या बेबी सुपाइन हुनुहुन्छ भने यो चेस्टमा राख्दा पनि भयो अनि कन्सोल गरेर बेबी मानिसकेर छोड्नु हुँदाखेरि अलवेज लिभ त तल्लो पार्टलाई चाहिँ छोड्ने बिस्तारै छोड्ने छोड्दाखेरि झटक्क भयो भने फेरि कभर गर्ने त्यस पछाडि बिस्तारै छोड्ने लास्टमा मात्र हात आउट राख्ने यो अगाडि निकालिदिँदाखेरि फेरि त्यो एजिटेटेड फेजमा पुग्नुहुन्छ त्यही भएर कन्सोल भइसकेर सबै बेबी स्लिपमा जानु भइसकेपछि अनि मात्रै बिस्तारै रिलिज यदि यो रिलिज गर्दा पनि फेरि त्यो कुनै साइन्स अफ स्टिमुलेसन देख्नु भयो फेरि ब्याक ल्याउने केही बेर पर्खिने र फेरि बिस्तारै रिलिज गर्ने पनि मान्नुहुन्छ समातिकलमा पनि मान्नुहुन्छ
युजली प्री टर्म चाहिँ क्रोन भनेर टर्म बेबिज टर्म चाहिँ क्रोनमा बस्न त्यसै
symmetric position in and flexion, and we have a contact eye to eye, and we explain him what we do. We can put in the mother milk and smell. Yeah, it's the milk of your mom. And you put on the trigger and make it pressure near the lips here.
हेड होल्डिङको फेरि बताइदिनु
होल्डिङ गर्दाखेरि तपाईँको हात अलवेज सी सेपमा हुनु पऱ्यो नाकि त यसरी गऱ्यो भने त तपाईँले यो गऱ्यो भने त चेप्ने भयो नि त त्यही भएर सी सेप हात सी सेपमा हुनु पऱ्यो अनि तपाईँको बेड अब कहिलेकाहीँ बेबीहरू अलिकति एजिटेटेड हुनुहुन्छ एक्सटेन्सन भयो होल्ड गर्न सक्यो तर चेप्नु चाहिँ पाइयो जस्ट यो फिङ्गरले होल्ड गर्न सक्यो त्यस पछाडि मान्नुभयो फेरि सी सेप यो कफ फिडिङ सपोज कफ फिडिङ गराउँदा बेबी असिमेट्रिकलमा हुन्छ बेबीलाई अपराइटली स्लाइटली पोजिसन मिलाउने अप या डाउन तपाईँको कुसन अनुसार स्लाइटली सिटिङ पोजिसनमा राख्ने र कुसनलाई तपाईँले बेबीको ब्याकमा सपोर्ट गर्नुहोस् यो कुसनलाई तपाईँले जस्तो सेप बनाउन खोज्नुभयो त्यस्तै सेप ब्याकमा सपोर्ट गर्नु फिडिङ गराउनु भयो फिडिङ गराउँदै हुनुहुन्छ तपाईँको हात अटोमेटिकली यो चेप्न पुग्छ यो एकछिनपछि आफै नै चेप्नुहुन्छ म चेप्दिनँ कन्फिडेन्ट हुन्छु म चेप्दिनँ भन्दा पनि चेपिन्छ किन भन्दा हाम्रो यो हात गर्छ नि त गलिसकेपछि कता न हामीले पनि स्ट्यान्ड लाउनु पऱ्यो नि त त्यसको लागि हामीले के गर्न सक्छौँ भने कि त हाम्रो हात लिन गरेर खुवाउनु पऱ्यो आफू कम्फर्टेबल हुन कि त हामीले बेबीलाई हामी कुर्सीमा बसेर लिएर खुवाउन सक्छौँ त्यो भयो त हाम्रो आफू कम्फर्टेबल भयो नि त कुनै पनि केयर गर्दा बेबीसँग आफू चाहिँ कम्फर्टेबल हुनु अनि केयर गर्नु भन्नुहुन्छ क्या त्यो भयो भने आफू कम्फर्टेबल भने जे पनि गर्न सक्यो नि त
फेरि किन स्पेसिफाई गऱ्यो भन्नुहुन्छ नि अनि त्यो छ भने चाहिँ त्यो सब हामीले यो ट्रागसबाट चाहिँ के गर्ने त जेन्टली प्रेस गर्ने है अनि आफू पनि कम्फर्टेबल हुनु पऱ्यो क्या यस्तो बेबीलाई फिडिङ गर्दै त अब मैले प्रेसमेन्ट भएको बेबीलाई गर्दैछु होइन अरू फिडिङहरू कफ फिडिङ जस्तो पनि गर्दा चाहिँ आफू पनि कम्फर्टेबल भएर बेबीलाई उठाउने त्यसपछि अहिले चाहिँ अब भेट्नु भएको बेबीलाई गरेको भएर अथवा हुन्छ नि अब बेबी चाहिँ प्यासिभ फिडिङमा छ ट्युब फिडिङमा भएको बेबीलाई त कफ फिडिङमा भएकोलाई त्यस्तो गर्ने ट्युब फिडिङमा भएको बेबीलाई चाहिँ अब गर्न मिल्यो जेन्टली प्रेस गर्ने 5 to 7 सेकेन्डसम्म बेबीले चाहिँ रेस्पोन्ड गरेँ ल अलिअलि गर्दा गर्दै गरेँ रे अलिअलि गर्दा गर्दै गऱ्यो भने चाहिँ मैले आउटर लिप इनर लिप गर्दै गर्दै उसले अझै रेस्पोन्स गरि नै रहेछ है गरिरहेछ भनेपछि यो इनसाइड गम्स गर्ने त्यसपछि बप्पल म्युकोसातिर लाने त्यसपछि अनि यो टङतिर लाने होइन उसले अलिअलि गर्दैछ त्यही भएर मैले कन्टिन्यू गर्दैछु तर यति गर्दा गर्दै पनि उसले चाहिँ यहाँसम्म आउँदा चाहिँ अलिअलि देखाइरहेको थियो एक्सप्रेसन तर यहाँनिर आएपछि उसले कुनै एक्सप्रेसन नै देखाएन यहाँ गरिरहेको छ मैले गएन भने चाहिँ स्टप गर्ने अनि फेरि स्टार्ट गर्ने यो हामीले कति टाइमसम्म गर्न मिल्यो भनेको थिएँ मैले 3 to 4 टाइम्स होइन 3 to 4 टाइम्सम्म गर्ने तर त्यसपछि पनि कुनै रियाक्सन छैन भने चाहिँ स्टप गर्ने र नेक्स्ट फिडिङ अब 3 to 4 आवर्सपछि अथवा नेक्स्ट उसको लागि चाहिँ हामीले गराउन सक्छौँ र पहिला स्मेल गराएर गर्ने बेबीले चाहिँ स्मेल गर्दा गर्दै पनि नजेस रिफ्लेक्स देखाइरहेछ भने चाहिँ हामीले फेरि पनि गर्ने चाहिँ होइन अनि एनइसीमा भएको बेबीहरूलाई गर्दाखेरि चाहिँ अब गरेर स्मेल चाहिँ गर्न मिल्यो तर त्यो मिल्कलाई चाहिँ हेभी डिप गरेर त्यो यसरी मुखमा लगाइदिने चाहिँ होइन किनकि एनपिओमा राखिरहेको हुन्छौँ नि त त्यही भएर अनि अर्को भनेको अब जस्तो बेबीले गर्यो रेस्पोन्स त्यस बेबीले यहाँनिर नेक्स्ट भनेको अब नेक्स्ट फिडिङ नेक्स्ट केयर गर्दाखेरि जस्तो अब हामीले फेरि गएर बेबीलाई चलाउने कुरा आएन हजुर त्यस्तो अब बेबीले मलाई दिइरहेछ पर्मिसन दिइरहेछ त्यो सब फिडिङ गर्नको लागि रेडी फिडिङ गर्नको लागि बेबी भन्ने कुरा गर्ने अनि त्यसपछि अब मदर अभाइलेबल हुन्छ भने मदरलाई त्यतिकै बस्नु चाहिँ नदिने क्या बेबीसँग कुरा गर्न दिने त्यसो हात एउटा हात यहाँ राख्ने भन्ने होइन अनि फिङ्गरहरू क्यास गर्न सक्छ मदरको होइन त्यस्तो गरेर गर्ने बोल्न दिने त्यस्तो गर्ने त्यसपछि यो पोजिसन आफ्नो पनि त्यस्तो गर्ने आफू पनि मेन्टेन गर्ने आफू पनि कम्फर्टेबल हुने त्यसपछि अनि फिडिङ सब स्टिमुलेट गरेर ओके छ फिडिङ लिनलाई रेडी छ भनेपछि अब फर्दर हामी नगइकन चाहिँ उसलाई कफ गराउन सक्यो कफ गरिसकेपछि पनि उसले चाहिँ अब बर्फ गराउनु छ भने हामीले गर्थ्यौँ पहिला ट्याप 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 गरेर प्याटिङ यस्तो गर्थ्यौँ त्यस्तोहरू नगर्ने वेट गर्ने बरु एकछिनमा त उसले गरिहाल्छ टाइम टेकिङ हुन्छ अब त्यही अलिकति पेसेन्स लेभल चाहिँ हुनु पऱ्यो त्यो हुन्छ अनि त्यसपछि अब हामीले उहाँहरूले चाहिँ पेसिफायर पनि युज गर्नुहुन्छ होइन हामी चाहिँ यहाँ पेसिफायर चाहिँ युज गर्दैन तर पेसिफायरले पनि बेबी चाहिँ ट्राई गरिरहेको छ एकदम हामीले पेसिफायर गरेर पनि स्टिमुलेट गर्न मिल्यो अनि तर त्यो टेपले टाल्नु चाहिँ भएन एकछिन आफूले होल्ड गरेर बस्नु पऱ्यो उसलाई त्यस्तो काम डाउन हुने बेलासम्म तर त्यस्तो टेपले टालिदिएर गर्ने चाहिँ भयो त्यति भयो भने चाहिँ उसलाई पनि सफोकेसन हुन्छ उसलाई पनि अब हामीले केही बोल्न खोजिरहेको छ हामीलाई अलिक कसरी मुख बन्द गरिरहेको छ भने त हामी पनि सफोकेट हुनुभयो नि त त्यसले गर्दा न्युरो डेभलपमेन्ट पनि असर हुनुभयो
बच्चा है यो चाहिँ कोल्याप्स बच्चाहरू ल टोन चाहिँ नभएको कोल्याप्स बच्चा जस्तो एचआईको बच्चाहरू हुन्छ नि एचआई 3हरू होइन जस्तो अब सेडिसन भएको बच्चाहरू त्यस्तोहरू हुन्छ ल मुभमेन्ट्स पनि भयो टोन पनि भयो अटो रेगुलेसन त हेर्नु भयो अब यो सबैजनाले स्केल पक्रिनु अलिक कलर गर्नुहोस् यो स्केल भन्ने तरिका सिकाउँछु ल अब चाहिँ फर्स्ट पेजमा चाहिँ राइट साइडमा पेसेन्टको नेम छ त्यसमा चाहिँ अब पेसेन्टको नाम के हो बेबी अफ फलानु अब लक्ष्मी सक्ने जो भयो पनि अनि त्यस पछाडि यतापट्टि डेट छ अब केयर पर्फर्म भएको डेट लेख्ने अनि जेस्टेसनल एजमा कति विक्स अफ जेस्टेसनको बच्चा हो 37 भन्दा लो हो कि 37 भन्दा हाई विक्स हो जस्तो हुन्छ 37 38 विक्स कति विक्स हो अनि एक्चुअल एजमा चाहिँ बच्चाको एज कति हो 1 डे 2 डे 3 डे 2 डे होइन कति डेजको बच्चा हो टाइप अफ केयरमा के पर्फर्म गरेको जस्तै बडी स्पोन्जिङ गरेको हो कि डाइपर केयर गरेको हो कि डक्टरहरूले एलपी गरेको हो कि एन्जिट्युबिङ गरेको हो कि होइन चेस्ट ट्युब इन्सर्सन गरेको हो कि जुन टाइप अफ केयरमा लेख्ने केयर रियलाइजमा के कसले हेल्प गरेको तपाईँलाई है विथ पेरेन्ट्स गर्नुभयो कि जहिले पनि हामीसँग 4 ह्यान्ड चाहिँ हुनुपर्छ केयर गर्दाखेरि एउटा आफ्नो भइहाल्यो 2 ह्यान्ड्स चाहिँ अर्को भनेको अब रिसोर्सेसको अनुसारले हामी नर्सेसहरू इच बेडमा 1:1 छैन तर जहिले पनि प्यारेन्ट्सको हेल्प चाहिँ माग्नुपर्छ है 2 ह्यान्ड्स प्यारेन्ट्स 4 ह्यान्ड्स चाहिँ हुनुपर्छ विथ कलेज हो कि एलोन गरेको हो कि एलोन पनि अप्सन राख्नु छ यहाँ तर अब एलोन चाहिँ सकेसम्म नगर्नु भनेर भन्छ ल लेन्थ अफ केयरमा कति टाइम लाग्यो केयरमा 20 मिनट्स 15 मिनट्स टाइप अफ केयर अनुसारले हुन्छ र यसमा भर्ने तरिका हो थ्योरी कुराहरू कभर भइसकेको छ अब बिफोर र ड्युरिङ केयर भनेर दुईवटा कलम छ त्यसमा चाहिँ दुईतिर भ्याकेट छ दुईतिर भर्ने हो जुन ठाउँमा पछाडि दुईतिर एकतिर सेड छ बिफोर केयरमा त्यो एक सेड भएको चाहिँ नभर्ने हो भ्याकेट ठाउँमा चाहिँ भर्ने हो र स्टेट अफ अलर्टनेसमा नाम स्टेट अफ अलर्टनेसमा भनेको चाहिँ अब बच्चा कस्तो छ बिफोर केयर डिप स्लिपमा छ भने मैले के भनेको थिएँ स्लिप साइकल कम्प्लिट हुन दिने उसलाई नचलाउने होइन ड्युरिङ केयर अब लाइट स्लिप छ भने चाहिँ उसलाई लाइट स्लिपबाट अवोइड गर्नको लागि आफ्नो भोइसहरूले सुदिङ भोइसहरू युज गरेर हुन्छ नि चाहिँ गरेर अब लाइट स्लिपमा गयो भने अलर्टमा गयो भने चाहिँ केयर पर्फर्म गर्ने बिफोर केयर केमा छ ड्युरिङ केयर चाहिँ के छ भन्छ है अब एगिटेटेड क्राइङ अवेकनिङ छ भने चाहिँ एगिटेसन ड्युरिङ केयर चाहिँ एगिटेसन भएको छ मैले केयर स्टप गरेँ स्किन टु स्किन टच गरेर बच्चालाई कन्सल्ट गर्नुभयो कि अथवा के गरी कन्सल्ट गर्नुभयो त्यो कुराहरू कमेन्ट्समा आएर लेख्ने ल जस्तो एब्नर्मल केही आइरहेछ भने कमेन्ट्समा चाहिँ तपाईँले के गर्नुभयो त प्रोसिड्युर स्टप गरेँ र मैले यो पर्फर्म गरेँ भने कमेन्ट्समा चाहिँ त्यो कुराहरू लेख्ने हो त्यही कुरा आउँछ कार्डियक सर्कुलेसन रेट पनि नर्मल थियो बिफोर केयर र ड्युरिङ केयर के हो
बेसिकली फोकस गर्ने टेपिङ र उयसमा यस्तो गरेको मलाई जस्तै यो हुन्छ नि इसिजी लिडहरू कतिले चाहिँ के गरिरहेको हुन्छ नि इसिजी लिडहरू पुरै डाइभरभित्र हालिदिएको हुन्छ पुरै ढामे हुन्छ कसैले फेरि त्यसले पनि तल खिचिदिइरहेको हुन्छ क्या टेप अनि त्यो तारहरू यहाँ हुन्छ नि त तारहरू बाहिर भने यो तल सबै राखिदिएको हुन्छ क्या अनि बिजाउँछ अनि कस्तो हुन्छ हाडै गरी कहिले काहीँ यो पनि याद गर्छ क्या एज अ प्रब्लम पनि क्या चेक हुन्छ नि कति प्रेसर पर्छ होला क्या है अलिकति बरु यतातिर गर्ने त्यसपछि त्यो प्रेसर नहोस् क्या हामीलाई पनि कुनै कुरा सुतेको बेलामा छ भने दामी पहिला ल्याटरल कम्प्लिट ल्याटरल पोजिसन राख्दाखेरि चाहिँ त्यस्तो हुन्छ तर हल्का पोजिसनमा राख्दाखेरि त हुँदैन तर अहिले हाम्रो विटामहरू कोही नै मान्दैन प्रोग्राम रेगुलेट गर्नको लागि त मैले हातमा माथि जानु पर्यो सिधै बल हेरिदिने साइड यहाँ टच गरेर बिस्तारै ल्याउन पाएको तपाईँले हामीले जब बिस्तारै राख्नु यदि यसरी राखिदिनु भन्दा पनि एक्सटेन्सन गर्न खोज्यो भने त्यसको साइडले गरिदिने एकछिनपछि अर्को भनेको कुसन अलवेज कुसन उल्टो गर्नु पऱ्यो उल्टो पनि सिधै युसेप होइन हजुर उल्टो पनि सिधै उल्टो युसेप होइन स्लाइटली सिस्टेम त्यस पछाडि बेबीलाई लियो बेबी यदि एजिटेटेड भयो भने ब्याक ल्याएर सपोर्ट नगर्ने यहीँ नै कन्सल्ट गर्ने होइन तपाईँलाई म पोजिसन मात्रै भन्छु होइन त्यस पछाडि ल्याएर बेबीको वान चिप चाहिँ यो उसमा रहनु पऱ्यो त्यस पछाडि यो चेस्ट र यो एब्डोमेन चाहिँ यही कुसनमा लाई गर्नु यो कुसनमा लगाइसकेपछि यो पोजिसनमा बसेपछि यो हात कहिलेकाहीँ यो हात आफै आउँछ र यहाँ ब्लकिङ हुन्छ त्यसलाई बिस्तारै लिन फरवर्ड यो सजिलो लिन फरवर्ड त्यस पछाडि अब यो सिधा भयो यो खुट्टा त यस्तो भयो बच्चा अवेक हुनुहुन्छ भने बोलिराख्नु पर्छ कन्भर्सेसन गरेर तपाईँले यो हात छोड्दाखेरि कन्भर्सेसन छोड्दा पनि केही भएन भने कन्भर्सेसन फेरि यदि गरिसक्दा पनि इरिटेबल भइराख्नुपर्छ एजिटेबल भइराख्नुपर्छ भने हात एउटा हात हेडमा सपोर्ट गर्ने अनि अलिक मानेपछि तलको हात छोड्ने टाउको स्लोली यो छोडिसकेर मानिसकेपछि टाउको पनि एकदम स्लो चाहिँ
अरू केही प्रश्न यताबाट तपाईँहरूको म्याम तपाईँहरू
Actually, I was not prepared. You put me on the spot. But I don't have any sort of questions because it's been 4 years I've been working in an ICU and almost everything is explainable. But like ups on our hands while providing care, unless it is contraindicated, like in disease conditions. But sometimes to protect us also, can we put the gloves? Like, I'm not trying to भन्नु खोजेको मिलिरहेको छैन बट म भन्छु तपाईँलाई
सेफ्टीको लागि लाउन सकिहाल्छ जस डिसी केयर दिँदाखेरि चाहिँ डेभलपमेन्टल केयर डेभलपमेन्टल टच दिइरहनु भएको छ त्यति बेला नलाउने मात्रै भयो भने वाइल वी आर डुइङ डायरेक्टल केयर
मर्निङ टाइममा केयर प्रोभाइड गर्दाखेरि
So her question is whether the caregiver should put on gloves or not while doing.
Gloves to box and केयर गर्दाखेरि चाहिँ स्पेसिफिकली लाउने कि नलाउने
Actually, there's very little conditions where you have to protect yourselves. If it's like staphylococcus infections, MRSA, so staphylococcus resistant, also Klebsiella maybe, but that's basic, and this is not very frequent in newborn. Sepsis, there's absolutely no risk for the caregiver if you don't put gloves. And yeah, if you put everything that is in, you put glove when you're going to do something that has biological, work with biological fluid. So basically it's changing a diaper, maybe it's better to put gloves. putting a gastric tube also, but that, or withdrawing blood, of course. But that's basically it. If it's just positioning and feeding, you don't need to put gloves when you do the feeding of the baby or the oral stimulation.
Whenever you are doing the imaging procedures, you can.
Because that is known to reduce infection between patients and nosocomial infections.
Thank you, sir. Just basic कुरा धेरै डिटेलमा चाहिँदैन एकजनाले भन्नु न डाइपर चेन्ज गर्दा के याद के गर्नुहुन्छ हाम्रो टिचर चाहिँ सुन्नु होला है
कुरा गर्दाखेरि पनि धेरै जेन्टली गर्नुपर्छ भनेर सिकेको छौँ अनि बेबीलाई चाहिँ बेबीलाई पोजिसन गर्दाखेरि पनि एकदम वान ह्यान्डले चाहिँ सपोर्ट गरिराख्ने र अर्को हातले डाइपर हेर्दाखेरि डाइपर चाहिँ सुरुमा नै हामीले प्रिपेयर गरेर राख्नुपर्छ स्क्विज गरेर त्यसलाई सफ्ट बनाएर राख्ने अनि त्यस पछाडि यसलाई क्लिन गर्नको लागि टिस्यु पेपरहरू पनि रेडी पारेर राख्नुपर्छ जसले गर्दाखेरि पछि चाहिँ अर्को ह्यान्डलाई पनि बेबीलाई सपोर्ट गरिराख्नुपर्ने हुन्छ नि एउटा ह्यान्डले त्यो चाहिँ ह्यान्ड मुभ नहोस् भनेर अनि सपोर्टिभ फुड गर्नु लगाइदिनुपर्छ पहिला चाहिँ हामीले अब त्यस्तो गर्दैनथ्यौँ होइन हामीले चाहिँ अलिकति बेबीलाई यस्तो उचालेर नै गर्थ्यौँ त्यो चाहिँ थाहा थिएन पहिला हामीलाई अब बेबीमा चाहिँ बेबीको पछि इफेक्टहरू पर्छ उसको चाहिँ डेभलपमेन्टल केयरमा चाहिँ पछि डेभलपमेन्टमा चाहिँ अलिकति इफेक्ट पर्छ भनेर थाहा थिएन त्यही भएर हामीले त्यसरी गर्थ्यौँ तर हिजोको सेसनले चाहिँ अलिकति त्यो कुराहरूलाई चाहिँ हामीले सिकाउनु हुन्छ
डाइपरलाई चाहिँ अमेरिकन पार्टभन्दा अलिकति डिस्टेन्समा राख्ने मेबी साइजलाई पनि याद गर्नु पऱ्यो साइज र सबसे बेस्ट थिङ भनेको चाहिँ सबभन्दा प्यारेन्ट्सलाई इन्भल्भ गर्ने मदरले फादरले इन्भल्भ गर्ने
दिदीहरू जुन 4-5जना हुनुहुन्थ्यो नि उहाँलाई पोजिसनिङको चाहिँ क्या अब जस्तै उहाँहरूले हिजो हामीलाई सिकाउनु भयो नि त पोजिसनिङ त्यो चाहिँ म त वार्डमा काम गर्छु नि त अनि त्यही भएर त्यो पोजिसनिङको चाहिँ हिजो उहाँहरूले सिकाउनु भएको थियो नि त्यो हामीले मदरहरूलाई जस्तै न्यू बर्नहरू आउनुहुन्छ नि हाम्रो एमसिस भन्न त्यो त्यसरी सिकाउन मिल्छ कि त्यो चाहिँ नर्मली यतिकै पनि उहाँहरूले यतिकै पनि जे सुकाउनुहुन्छ नि त त्यो गर्न मिल्छ कि नर्मल डिफ्रेन्स हुन्छ अब जस्तै प्रिटर्म र टर्म बेबीहरूलाई त्यो पोजिसनिङको
इच एन्ड एभ्री प्यारेन्ट्सलाई जो मदर साइड बेबी हुनुहुन्छ एनआइसियुमा हुनुहुन्छ नर्सरीमा एमसिएचमा जहाँ जुन वार्डमा भए पनि हामीसँग कुकुन एभाइलेबल नभए पनि हामीसँग सानो ब्ल्याङ्केटहरू त हुन्छ नि त इभन समर ब्ल्याङ्केटहरू हुन्छ जस्तै सफ्ट क्लोथ्सहरू जे हुन्छ ब्ल्याङ्केटै भन्ने चाहिँदैन सफ्ट क्लोथ जे हुन्छ त्यसलाई रोल गरेर कुकुनको सेपमा बनाएर त्यसमा बेबीलाई एडजस्ट गर्न सकिन्छ पोजिसनिङ गर्न सकिन्छ हामीले मदरहरूलाई सिकाएर मदरहरूले सिक्नु भएर घर जानुभयो भने त्यो हाम्रो लागि त झन् बेनिफिट भयो नि त बेबीको न्युरो डेभलपमेन्टमा हामीसँग हुँदा मात्र न्युरो डेभलपमेन्टमा हेल्प गऱ्यौँ होइन नि त उसको न्युरो डेभलपमेन्ट त मदर फादरले पनि गर्ने हुनुभयो नि त त्यसमा पनि हेल्प हुन्छ हामीले सिकाएरै पठायो भने त त्यो त झन् बेस्ट पार्ट भयो
केएमसीमा के गर्नुहुन्छ रिगार्डिङ फिडिङ सरी ट्युटिएस
नमस्ते सबैजनाले हामीलाई ट्रेनिङ दिइसक्नु भएको छ भनेर त्यस्तै क्लासेसहरू भयो ह्यान्ड अन ह्यान्ड सेसनहरू पनि भइरहेछन् अनि फेरि नेक्स्ट 2 टाइम्स आउँदै हुनुहुन्छ र यो हेर्दाखेरि फर्स्टचोटि आउँदाखेरि चाहिँ हामीलाई पनि यो सम्भव छैन पोसिबल छैन जस्तो लाग्थ्यो होइन सबैजना त्यस्तै लाग्छ हाम्रो विचारमा चाहिँ फर्स्टचोटि हुँदा चाहिँ यसरी चाहिँ हामीले काम गर्न सक्दैनौँ वार्डमा काम भ्याउनु नै यसको इम्पोर्टेन्स झन् बढी छ भन्ने हामीले फिल गर्दैछौँ सो त्यसको लागि चाहिँ एकदम थ्याङ्क यू भन्न चाहन्छौँ डक्टर स्टेफेन अनि उहाँको ग्रुपलाई है अनि हामीलाई यस्तो सिकाउँदै हुनुहुन्छ र यहाँ त अलरेडी 5जना नर्सेसहरू डिसी नर्सेसहरू भइसक्नु भएको छ सर्टिफाइड भइसक्नु भएको छ हाम्रो हस्पिटलमा चाहिँ नि फर्दर हामी प्रोसेसमा छौँ इक्जाम हुने प्रोसेसमै छौँ तर तैपनि त्यसबाट पनि हाम्रो एज अ होल हामी जतिजना हामी नर्सेसहरू यो 5 टाइम्स क्लासेसमा बसिसक्यौँ एज अ होल पिडियाट्रिक्स डिपार्टमेन्टको मोस्ट अफ द नर्सेसहरू चाहिँ पढिसकेका छौँ र त्यही अनुसार हामी प्र्याक्टिस गर्दैछौँ केयरहरू प्रोभाइड गरिरहेछौँ र त्यसबाट चेन्जेसहरू चाहिँ हामीले फिल गरेका छौँ र त्यही अनुसार फ्युचरमा पनि अझ धेरै हामी पर्फेक्सनमा जाँदैछौँ भन्ने जस्तो लागिरहेछ त्यसको लागि चाहिँ नि सबै एज ए होल BPKIHS टिम अनि हाम्रो डक्टर स्टेफनको टिमलाई चाहिँ थ्याङ्क यू भेरी मच भन्न चाहन्छौँ
डिसी केयरको सेटअप त्यहाँ कस्तो छ के गर्नुहुन्छ थोरै भनिदिनुहोस् न होइन त्यसपछि हामीले उहाँहरूलाई पनि एक्सपर्ट्सहरूलाई पनि हामी उहाँहरूको पनि ओपिनियन लिन्छौँ उहाँहरूको के छ त्यहाँको एक्सपिरियन्स।
नेगोसिएसनमा रहेका छौँ। हाम्रो वर्कसपको सेकेन्ड डे रहेको छ र हाम्रो यो जस फिडब्याक सेसन भनौँ अथवा हाम्रो के भन्ने रिक्यापमा चाहिँ हामीले जस अब हाम्रो एक्सपिरियन्स सेयर गर्दाखेरि चाहिँ 2016मा र 2017मा चाहिँ म गएकी थिएँ डेभलपमेन्टल केयरको ट्रेनिङ भनौँ अथवा जस अब अब्जर्भेसन भिजिटको लागि। अनि जस हामीले जुन अब उहाँहरूले हामीलाई सिकाउनु भएको कुराहरू नै उहाँहरूले अप्लाई गर्दै गइराख्नु भएको छ। उहाँहरूको चाहिँ एनआइसियू चाहिँ अब एनआइसियूको त्यो डोरमा छिर्ने ठाउँबाट नै जस अब एनआइसियूमा भएको बेबीहरूको चाहिँ कस्तो हुने रहेछ भनेदेखि त्यो एनआइसियूमा बसेको बेलादेखिको फोटोहरू बिस्तारै अनि फेरि पछि फलोअपमा आएको फोटोहरू त्यो बेबी कस्तो भयो भनेर जस्तो हिजो देखाइराख्नु भएको थियो नि मिहाई म्यामले त्यस्तै खालको त्यो फोटोहरू राखिएको हुने कि त्यस अब टिभी जस्तै क्या के हो त्यो टिभी हो भने फादरको फोटो होइन मदर चाहिँ अब त्यस अभाइलेबलै हुन्छ भने त्यस अब मदर चाहिँ सँगै नै बसिराख्नु भएको हुने प्रायः। अनि केएमसीहरू पनि हामीले जस्तो फादरले केएमसी गरेको देखेको थिएनौँ नि त फर्स्ट टाइम जस्तै उहाँ फादरले केएमसी गरेको देखेको। त्यसपछि हामीले यहाँ BPKIHS पनि आएपछि हामीले फादरलाई पनि केएमसी गराउनु पर्ने रहेछ भनेर त्यो कुरा चाहिँ हामीले यहाँ त्यस 2016मा त्यहाँ गएर आएपछि हामीले एउटा प्रेजेन्टेसन पनि राखेको थियौँ। अनि त्यसमा चाहिँ हामीले यही कुराहरू के जुन हामीले कसरी बेबीलाई टच गर्नुपर्ने रहेछ कसरी बेबीलाई चाहिँ हामीले जस अब पोजिसनिङ गर्नुपर्ने रहेछ कुकुलिङको कुरा पनि थिएन। कुकुर पनि हामीले त्यहीँ देखेको हामी त त्यही भने नि मैले हिजो नेस्टिङ गर्थ्यौँ नि त त्यो के अरे ड्र सिटमा चाहिँ कटन बिछाएर कटनलाई ऱ्याप गरेर अनि त्यो उयो गर्नु क्या नेस्टिङ भनेर भन्थ्यौँ थाहा थिएन कुकुर भनेको। त्यहीँबाट आएर चाहिँ हामीले कुकुर बनाउनु पर्ने रहेछ भनेर हाम्रो एकजना दिदी त्यसको लागि चाहिँ श्रेय चाहिँ रूपा दिदीलाई दिनुपर्छ उहाँले चाहिँ सोचिराख्नु भएको रहेछ। अनि हामीले चाहिँ सोच्नु त सोचेको थियौँ तर अब त्यो तरिकाले बनाइहाल्ने भने चाहिँ थिएन होइन। उहाँहरूले पछिबाट हामीलाई मटेरियल्सहरू त ल्याइदिनु भयो तर त्योभन्दा अगाडि नै हामीले चाहिँ रूपा दिदीले जस इनिसिएसन लिनुभयो र हामीले कुकुरहरू पनि बनायौँ। प्लस जो भए पनि घरको मान्छेहरू यस गर्न अनि त्यो सबै के अरे सिब्लिङ्सहरू के त्यो पनि त्यसमा उहाँहरूले पनि भिजिट गर्न पाउनुहुन्छ जस्तो हामी यहाँ त दिँदैनौँ नि त सिब्लिङ्सहरू अलाउँदैन तर हाम्रो त अब यो उसले गर्दा पनि होला क्या जस्तो अब ओपन डोर सिस्टम हुन्छ नि त उहाँहरूको त एउटा जस्तो क्याबिन जस्तो हुन्छ त्यसले गर्दाखेरि पनि उहाँहरूको पोसिबल भएको ट्याब्लेट साइड हुन्छ होइन। अब त्यो हाम्रो चाहिँ अलिकति इन्फ्रास्ट्रक्चर नै चाहिँ
डेभलप हुन्छ र अन्त्यमा गएर मात्रै अडियो भिजुअल डेभलप हुने हुनाले चाहिँ साउन्ड र अब यो जुन सिक्वेन्समा डेभलप हुन्छ नि सिस्टम त्यसमा डिस्ट्रप्सन आयो भने प्रब्लम हुन्छ क्या। सो अडियो भिजुअल सिस्टम लास्टमा डेभलप हुनु भएको हुनाले तपाईँले अगाडि नै लाउड नोइज लाउड तपाईँको भिजन होइन लाइट के अरे ब्राइट लाइटहरूसँग एक्सपोजर भयो भने त्यो मेजोरेसनमा डिस्ट्रप्सन आउँछ क्या अनि त्यसले गर्दा लङ टर्म इफेक्ट हुन्छ। त्यो भएर अन्त्यमा चाहिँ सानो एउटा कुरा भन्छु कि जस्ट एड्रेस द अलार्म आफ्नो एनआइसियू एरियामा जहाँ जानुहुन्छ आफ्नो इभन नर्सरीमा पनि कुनै अलार्म बजिरहेको छ भने प्लिज एड्रेस गर्नुहोस्। वार्मरको अलार्म होस् इन्कुबेटरको अलार्म होस् होइन भेन्टिलेटरको अलार्म होस् भने अलार्म एड्रेस गर्नु भएन भने के हुन्छ त्यो एउटा बानी पर्छ क्या टुटुट गरिरहेको छ भने त्यही टुटुटुमा काम गर्ने बानी लागिसकेपछि के हुन्छ बच्चा डिसेचुरेट भइरहेको छ कि थाहा हुँदैन एउटा कुरा त अर्को उनीहरूको बच्चालाई प्यासिभली हार्म गरेर हुन्छ होइन।
Also our wonderful trainers from BPKIHS Dharan, and we got to learn about the basic principles of developmental supportive care like the cue-based approach and individualized approach for care of infants, family-centered care involving parents as much and promoting sleep and rest and overall promoting a healing environment in the NICU. So and we also got to learn about the different skills like the positioning, oral stimulation, and how to give gentle care, while different skills like diaper change, and we also saw about the different neurobehavioral states of the baby. So these are the core areas of developmental supportive care, but there are also many other things that we are supposed to do in NICU and we are already doing in NICU. They are also part of the developmental supportive care. For example, if we do a very good temperature management of the NICU, that also helps in the better neurodevelopment of the baby, right? Right. So and if we optimize the nutrition of the baby, that is also in a way developmental supportive care. Many of us are already practicing kangaroo mother care. That is also a important part of the developmental supportive care. Similarly, there are some small things in the babies who are on respiratory support that should be done to promote a better neurodevelopment in those babies. So we'll talk about those. So these are the common respiratory support that are used in only ER ma काम गर्ने ICU ma काम गर्ने basically उहाँहरूले use गरेर भएको live intubated patients हरुमा हैन. And in our setup also we use apart from CPAP and high fluid nasal cannula we are not using, but maybe some other centers may be using. So and these are the core principles of developmental supportive care that we discussed. And what are the challenges for the infants on respiratory support? Respiratory support, what are the difficulties in providing the appropriate form of developmental supportive care? One thing is there is the extra equipment, the tube that is going to the airway of the infant, or the interface that is going over the nose. Positioning of the baby that is also constantly disturbing the baby. The comfort of the baby might be compromised because of that. The sleep may be compromised because of that. Right? And many times they are also the sick babies, the infants on, especially the infants on ventilator, mechanical ventilation. They are also the sick babies who also have the extra lines like umbilical lines or PICC lines or sometimes even central lines in those babies. So all of those create problem and many times they also require frequent assessment. Right? Sick baby or not. Interface or so we have to not we have to, but generally these infants get disturbed time to time. So the noise exposure may also be more because the rounds may get prolonged. There is discussion round may is taken to show the interface, but that problem is there. She is covering the entire upper half of the baby. And this the commonly used interface. Like I said, we commonly use this Rams cannula. This is a nasal prongs, and this is the Hudson prongs. And we also frequently use the nasal mask, right? And duoderm. So this is a gel-like material, and when it's applied over the skin, it also absorbs the moisture and becomes like a soft material. And you can see in this picture that the prongs is being kept over there. So what it does is, like, since the interface is not directly rubbing over the nose, directly in contact with skin contact with the interface, so the friction injuries are prevented, right? And next is because it's soft water, pressure injury can prevent. So direct pressure or friction water injury common. And another good thing about this is that you can put it under the adhesive. So if you are using the ET tube, ET tube tape problem. Skin injury, skin को part में कहीं आउँ सकती है, इसमें injury और गला हो सकता है, right? इसको उन्हीं पर ये लगाना सकते हैं, right? So we can apply this layer of duoderm over the skin, and over that you can put the tape. And when you remove the tape, because you are not removing from the skin, the injury is not that much. And when you have to remove this layer, so your layer says skin but that does not cause much of the problem because it easily comes off, right? So this can be put underneath the interface. This can also be put underneath any form of adhesives like the ET2 plaster or the tapes that you use to fix the NG tube or OG tube. And this can also be used beneath the ECG leads also. And ECG lead को So this we have to cut according to our requirement. This usually is available in the 6 inch by 6 inch size. You can cut according to your requirement. And this is like ready-made available in this shape, so you can directly apply it over the nose area. What we can do is, just the ET tape laga so we can also moist directly remove you can moist the tape with the saline gauze, and then instead of directly removing it forcefully, you can just support the skin at one place and then remove the tape slowly so that the skin does not get injured, right? And positioning in the respiratory support. So even if this may cause slight difficulty, but because you have to handle the tubings and the extra equipment, but we have to avoid like hyperextension and hyperflexion. For any baby, hyperextension or hyperflexion is not good, but especially if those babies who have respiratory problems, we should not be doing excessive extension or excessive flexion. And special attention to the ET tube, like while changing position or while doing anything, you have to give attention to the ET tube, because if the accidental extubation or tube displacement is not a good thing, right? So if the tube gets displaced and baby suddenly desaturates, then first what we'll do is के गर्छन् हामीले पहिला डिस्याचुरेट भएको देख्छौँ किन डिस्याचुरेट भयो सक्सन गर्नुपर्ने हो कि के भयो अस्कल्टेट गर्छौँ त्यसपछि यो ट्युब डिस्प्लेस भयो ट्युब निकाल्छन् त्यतिखेरसम्म कतिचोटि ब्राडिकार्डिया भइसकेको हुन्छ एन्ड देन यु गिभ ब्याग एन्ड मास फर्दर then you have to give bag and mask many times and then reintubate. So lots of discomfort. So accidental extubations and tube displacement should be prevented by all means. So one strategy what we can do is like instead of tube fix instead of putting the tube like this, we can cross it to the opposite side. Yeah? So if you cross it to cross the opposite shoulder like this, frequent inspection of the loosening of the like we discussed earlier, lose on side. तर बेबीको सेक्रेसन पनि कतिचोटि भिजिरहेको हुन्छ र ट्युब लुज भइरहेको हुन्छ सो भिजिरहेको छ लुज भइरहेको छ भने ल ठिकै छ भनेर छोडिदिनु भन्दा त्यति बेला नै चेन्ज गर्नुपर्ने हो कि सो त्यो टाइमली चेन्ज चाहिँ गर्नुपर्ने है एन्ड हाइड्रोकोमेट्रेसन आई हेभ अलरेडी डिस्कस्ड राइट सो अगेन एनी प्रब्लम इन दिस पोजिसन अफ द बेबी क्लियर सायद छैन होला CPAP for NIV and regular pool change of position is also helpful to prevent CPAP. And airway maintenance. So, why is humidification important? At some point, we did not have any humidification in our unit because of the lack of humidifiers at that time. So, what we noticed was there was very high, frequent incidence of tube blocks and then nasal blocks and excessive nasal secretions, and that leading to nasal trauma. That can many times because the tube block you increase the settings and because the pneumothorax by inside. So humidification is very important. And then this is the coordinated care, right? And we that it should not be a one person doing the positioning or one person changing diaper. It should always be preferably at least 2%. It can be 2 to 4%, like you can see in this picture, right? One person should always be there for containment of the baby. And because the baby, we are talking about baby getting displaced during the positioning of the baby, right? And one person should be containment भनेको एकजनालाई चाहिँ समातेर बेबीलाई कम्फर्ट दिने हैन त्यो गर्नलाई पनि एकजना मान्छे चाहिँ चाहिन्छ है and avoid making sudden movements हैन बिस्तारै गर्नु पर्यो. And what is the problem with this is that we need extra manpower हैन एकजना दुई तीन जनाले गर्ने भएपछि you need more people. But what you can utilize is you can utilize the parents, both mother, father, and you can also utilize the doctors who are there in the NICU during the position. If you utilize the doctors also, then they can also do the assessment in the same setting, and then baby did not be disturbed again and again, right? And if the helper staff, if you give them some basic training, then they can be also utilizing these things. Of course, you have to train them regarding hand hygiene and regarding what you are going to do and what they are supposed to do during that procedure. But you can do that. Helper staff can also be utilized for this, right? The ventilator will have alarm, the humidifier will have alarm, the water will have alarm, the infusion pump, right? Rounds and prolonged this discussions, and even during the handover, right? Handover ko bela pani kaile huncha ni alikati awaz. So the staff who has finished the duty will be frustrated because of the busy duty, and the staff who has just arrived will be excited over what's going on with those babies, right? So all those discussions should be as away from the patient as possible. Only the minimum assessment that you need to do should be with the patient. Or discussion or patient but जति सकिन्छ टाढा हैन त्यसरी गर्यो भनेदेखि it will be better for the neurodevelopment of the baby. And one thing that we need to do is optimize the alarm limits and optimize the alarm volumes हैन दिनमा र रातमा एउटै खालको volume नचाहिएला. Night it's more quiet, so you can slightly decrease the alarm volumes, and limits also need to be changed. Right? For example, if a patient if a baby has heart disease and the saturation is between 70 to 80%, then you need not, if you keep the usual limit of 90% or 88%, then the alarm will be continuously ringing. Right? So just like you should make frequent assessment in each shift, like what is the appropriate alarm limit for this baby, and change the setting so that the alarm does not sound off again and again, right? Because if there's too much alarm all the time, then you'll not be attending those alarms, you'll be ignoring those alarms, right? So, and then many times the sick baby may get missed and unattended because of those frequent alarms which is being ignored because they are too much. Make a dim light, you can keep the 12-hour cycle so that the baby also has the time to develop the circadian rhythm. Dim slightly more like this one. If the baby does not require frequent procedure or frequent monitoring, then you can allow less light in that area. Right? Next is the pain management. So routine IV sedation should not be the ventilator setting is not appropriate, or baby has discomfort because of some reason, so the baby is constantly moving and the asynchrony is the ventilator is there and baby tends to desaturate. Many times what we should try to do is try to find out what is causing discomfort to the baby and optimize the ventilator settings. So many times if you optimize the ventilator settings, give the adequate support as needed by the baby, then the asynchrony will not be there and baby will be comfortable even without any sedations also. So giving IV sedations should only be the last resort where it's too much of asynchrony despite your all efforts, or in some babies like in the PPHN or management sedation or action. Otherwise the sedation, IV sedation should not be used. We should try to make the baby comfortable in the other non.
This is as important as just the developmental care itself. So I think it's an addition, a very important addition to this 2-day symposium. So thank you.
Thank you very much, sir. Would you like to add something or share their experience? Yes, thank you very much.
So, I can see ma'am is here with us. Good morning, ma'am. Welcome once again. So, now we have session for breakfast. Breakfast is in breakfast was just agadi. हामीले अगाडि कन्टिन्यू गरिरहेको सेसनलाई नै अलिकति कन्टिन्यू गर्छौँ होइन. हामीसँग डिएम न्युरोलोजी रेजिडेन्ट हुनुहुन्छ केएमसी काठमाडौँबाट डक्टर एन्जिला घिमिरे एन्ड डक्टर दिपेन्द्र राय. सो उहाँसँग मेरो प्रश्न थियो कि डिसी केयरको कन्टेक्स्ट.
Thank you so much, Dr. Prakash. Good morning, everyone. So, I have enlisted a few. It's not as well developed as it is here, but still we are trying to incorporate so many things. So we actually had a 40-bed neonatal unit previously. Now we have sized down to 25 beds because we thought that our care was not optimum as per the developmental. So with the constraint of the staff and the healthcare members, so we thought that the number of staff were not adequate to provide as good care as possible. And then, so if it's a preterm delivery, so we usually delayed cord clamping. So previously we did not used to do delayed cord clamping. However, nowadays we approach the visitors or the family antenatally as well. And then if it's a high-risk delivery, so the family-centered care is incorporated before the birth of the baby. So we do a proper antenatal counseling. And then because we work in a private hospital setup, we also explain about the, let's say, if it's a high-risk baby, so let's anticipate a little bit longer duration of hospital stay and what would be the role of the family members, the parents, the father, the grandparents, and also if it's going to be a long-term stay in the hospital, so who would be the appropriate person if the father has to go for work. So we discuss all these things in the antenatal period also, and then after planning the delivery, so we attend the delivery. So delayed cord clamping nowadays you are practicing. Then when in preterm babies we do the plastic wrap. So after that we shift the baby to the NICU, and then in NICU, so we usually, as compared to previously, we encourage early enteral feeds and mother's own milk. And unfortunately we don't have a lactation management unit in our center, so we use mother's own milk. Sometimes with consent, we use express breast milk of seronegative mothers with consent to other babies in our unit. And after that, the feeding progression is quite, I'm seeing man. And we also know that that's not the optimum care, ma'am. And then after that, early interval feeding we promote, and then after that, so we also practice intermittent KMC inside the NICU. So we have like not a proper KMC chair or bed, however we have a comfortable, a set of comfortable sofas where either the mother or the father or the grandmother, anybody like who is interested, any relative of the baby who is interested, so we ask them for visiting the baby and then continue intermittent KMC. While saying this, we also did a quality improvement project in extending the KMC duration. So in a few babies, we were able to achieve almost as long as 10 hours of KMC, intermittent KMC though. And then after that, while doing the procedures, we usually, in our center, our team is still not comfortable with keeping the parents during the procedures inside the unit. So we usually, for the non-pharmacologic approaches, have facilitated talking and the swaddling, and then we use the 25% dextrose. We call them lollipops. We spread the 25% dextrose on the gauze, sterile gauze, and then we ask the baby, like we offer it to the baby to, suck on that, and then we perform procedures, and we use analgesia during invasive procedures. However, we haven't used those topical creams, we haven't used those things. And then others, did I leave anything? Enough that we have good monitors and ventilators where we can control the light and sound. And in our unit, so we can individually dim or off the light for each, like at least 2 beds at a time. So that has also helped much for light reduction. And however, there's still a long way to go. And like the structured developmental care, and then the positioning, and then diaper care and everything, whatever we learned yesterday. So we haven't been doing those things in the proper manner. That's why we are here, and we are learning a lot of things. Thank you.
Or maybe we can do it after the breakfast. Maybe we can, breakfast is already ready, we can do it after the breakfast.
You probably all have seen these videos or pictures of a fetus sucking their fingers. And actually, preterm baby of 28 weeks is still a fetus, so he's not at the right place, you can say it that way. But it's still a fetus, it's not mature, it's not a German newborn. So the non-nutritive sucking is actually a normal reflex that you must keep active to introduce the nutritive sucking after 34 weeks. So it is important to keep it. It's also a very good auto-regulation mean for the baby.
And Professor Nisha ma'am has always been the iron lady of Department of Pediatrics, as we have known. And I just wanted to add of something. Yes, developmental supportive care is very important. We have to take care from the beginning. It starts from the birth, but most of the time, actually more predominantly in the extremely preterm, those who are 800 grams. So what happens is the more the time goes on, they start getting sicker and sicker. And to take care of them, it will be a very big challenge, because the blood works will keep on coming up, and we'll be checking heel pricks for glucose, the diaper changing will go on, and there will be so many handlings. So much of the time we start losing hope in these sicker children, time and again.
If you'll see what we work of in NICU and all, we work for a 0.001% also. We don't give hope till the last. And that's what is the teamwork and coordinating and making them with others makes the hope come, right? That's why there are so many babies, lesser than 1,000 grams, we are able to save, we are able to give. So to make the team work together, it's not only that time or this baby or 800 grams, or this is whole team every day you work with the whole team. Though we feel sad for losing the baby, but see what has been occurring from the so many years of the care you people are giving and everyone is giving here.
Work to keep your team with a good pace and a good atmosphere, even in the difficult moments that every NICU goes through and every person in the NICU goes through. In terms of developmental care, more specifically, it's also a challenge and a daily battle to keep it up. Yeah, we're doing that since 25 years. There's still some people that say, oh no, it's too long, I'm not interested, I don't want to do it of the baby, the parents, aside of just the normal medical care that we are providing. But yeah, you have to support your team every day, that's for sure.
Changing habits take time. So even if you are going to introduce DC care in your setup, after going on from here, you have to ask your colleagues, your other staffs frequently. So you as a so frequently emphasize. So we'll now break for the breakfast session. So we have 30 minutes time. We can all move downstairs. By none other than the stalwart of DC care, the person who has spent years in just developmental care, our very beloved, who is also like one of our family members now, the boss, Professor Dr. Stephane Sizonenko. So I would like to hand over the mic to him now. Thank you.
I'm just the one that organize everything and make it happen. Okay, so the topic I'm going to talk about will go probably a bit more into biological process and actually some evidence of how developmental care is important for the brain development of the baby. Complex suite of during gestation, There's neuronal proliferation, neuronal migration. After, there's the radial glia, important cells that actually disappear during development, but they're important to guide the neurons to the places from the center where they are born to outside in the cortex. The subplate neuron also are important because they are also transient neurons that support the activity of the neurons that come from the deep part of the brain to the cortex. So they kind of do the transition and keep the neurons from below alive with neuronal activity. And then when the cortex is formed, the neurons connect, the deep neurons connect to the cortical plate, and these subplate neurons are disappearing also. Then there's organization with neuronal orientation, interconnection of neurons, synaptogenesis. There's also glial differentiation for improving the transmission of the neuronal signal. As you can see, prematurity happens out of these processes that are going on during the prematurity period, and we have to support this process during this period. And prematurity alters this process. There's also the cortical folding that takes place. There's an important connectivity development. I won't go too much in the details, but as I'd already told you, before 20 weeks, there's the subplate layer, which is a transient layer that helps the overall brain and cortical cortex to develop, that are abundant in the subplate that are present and will push to 24-32 weeks. There's this thalamocortical afferent, so from here that goes into the cortex, so it's already the future normal brain structure. And 32-36 developing brain has a high plasticity, and around 200 million of children under the age of 5 do not actually fulfill their cognitive and social and emotional developmental potential. Despite this high plasticity potential, and this cerebral plasticity is the ability to learn, to remember, to forget, to reorganize, or to adapt and recover from injury. Neurogenesis, so new neurons, and synaptogenesis, connection between neurons, are the activity-dependent mechanisms that are underlying mechanism from the areas that were destroyed from the other areas surrounding. So this is the plasticity. The brain is able to correct an injury partially. This is also another experiment in animals where it's just they measured maternal care. So this is in rats. Maternal care on the dendritic morphology of neurons of the dentate gyrus, and they classified the animals in low maternal care and high maternal care, and you can see that the picture of the neurons is different, with more dendrites in the high maternal care group. You can do some measurements. Dendritic complexity is higher in the high maternal care. The number of spines also is higher in the maternal group in different area of the neurons. So maternal care is important for brain development. This is the same experiment, but here they looked at activity of the neurons. And you can see that the high that are in black, the high maternal care. So this is really electrical activity of the neurons. I would like to show you a case report we had in a newborn baby. He was a term newborn. He did some apnea and vocal left temporal parieto-occipital stroke injury that you can see here on day 4. These are magnetic resonance imaging. This is 6 weeks after, basically some brain missing, a big hole on the temporal parietal adoccipital side. 3 months, at 12 months and 20 months. So basically the structure imaging, and you can see that it didn't come back. And this, the optical nerve and the optical areas. We did a functional MRI, so stimulation of the baby with light. When in the MRI, and we could look at the activity of the brain. You can see that here with light, so visual stimulation at 3 months, there's only the side where there's no injury that lights up, the other side there's nothing. Okay? This is at 3 months of age. You can see that it lights up, and this is a bit more complicated picture because it's after it's putting together the functional results also with what we call diffusion tensor imaging, which actually shows you the microstructure of the brain. You can see that there's some small arrows that show you. So you can see here the arrow is actually the optical tract. They have smaller volumes of the cerebral cortex and the white matter. They have a reduced sulcal complexity. They have an altered thickness of the cortex, and they have an altered activation of the of cortical areas when you do a functional MRI and a resting. And this is translated by some behavioral changes. Here, this is the big Epicure studies in the UK. EP is the extremely preterm, and this is term comparison. And you can see that in terms of sensorial, in terms of visual spatial, also the extremely preterm have a lower score, and also in terms of attention and executive function. So again, another global difference with extremely preterm infants in terms of is a big modulator of brain development. So we have preterm, we take care of preterm babies. We have environmental stressors. NICU is environmental stress. We have to do some bloody work, suctioning, intubation, chest tubes, anything that is painful, and behavioral response to all that. And you know, you heard that yesterday with finger spanning, grimacing, etc. So baby is adapting to what the pain and the stress he's receiving. Of course, there's also some individual difference from babies. Some babies are more difficult to handle than others. But all this gives physiological response with increase of cortisol, the stress hormone. That the neonatal infant stressor scale, and just a simple measure, which is the bifrontal diameter, which is a good surrogate measure for the brain size. And you can see the higher your score of stress is, the lower your brain. The same kind of results, but here they looked at the relative anisotropy that we get from the diffusion tensor imaging, which is a marker of microstructure organization in the white matter. I looked at long-term outcome. This study was done in teenagers that were preterm, and what they saw is that there is an alteration of diffusion and neural connectivity in the temporal lobes. Here you have the control term group, which have nice connectivity and activity symmetrical. The low stress preterms have also both sides, probably a bit less on one side. This is if you look at the high stress preterm, they almost lose activity and connectivity on one side. Okay? So the more stress you have, the more connectivity you do not develop. Actually, you don't lose it. You do not develop it. Going back to animal experiments, this is maternal separation. So stress during early life, especially for humans yet, of course, especially for there are several times of separation, and you can see that it goes. This is the black is the separated pups, and you can see that it goes up between 5 and 30 minutes, and then it goes back down when you put the pups back at 60 minutes with the moms. In the hemisphere, and you can see that the maternal deprived have a lower number of neurons, and this is the cell density showing the same. It's still the same study, but they looked at something more specific, which is synaptophysin, which is actually a protein very important to making the sign. You can see that they looked at different areas of the brain, the hippocampus, two areas of the hippocampus, the amygdala and the prefrontal cortex, and you can see that the deprived animals, still in back, have a different activity of dendritic formation measured through synaptophysin. They did some behavioral tests. First they measured the deprived in the maternal separation group, and they did the high elevated plus maze, which is a maze which it's a cross and it's above the floor about 1 meter, and 2 arms are covered and closed and 2 arms are not, and you actually measure the number of times. It's an anxiety measurement test, and you measure the times, the number of times the rat goes into the open one, where there is more anxiety because it's high over the floor. And the rat that were separated from mothers go much more less into the open arms, because that's. This is another activity, electrical activity, what we call long-term potentiation activity measure, and you can see that there's a better response in the animal that were not isolated compared to the one that were isolated from the mother. So stress changes your activity in terms of behavior and the neuronal electrical activity. And what we did is in utero exposure to dexamethasone, which mimics maternal stress, and we used what we call spectroscopy imaging, and we can measure different metabolites, brain metabolites, like phosphocreatinine, GABA, and acetylacetate, which is a marker of neuronal integrity. And what we could show is actually that exposure to dexamethasone changes these metabolites that are important for normal metabolism, neurotransmission, structure of the brain. When you look just at the histological picture, this is the hippocampus. Don't look at this one, just look at this one, the 2 first ones. This is the control. You can see a lot of blue dots, which are neurons, and there's less of these blue dots in the stressed animals. Of the brain of these rats, using the same technique I just talked before, diffusion tensor imaging, which actually looks at the water diffusion into the tissues. And what we saw is that there was a reduction of diffusion of the fractional anisotropy, so a change of the microstructure in the rats that were stressed with dexamethasone. Italian study where they looked at the quality of developmental care in NICU and health-related quality of life in preterm infants later on. So there's two infant-centered care, and you can see, so they did a classification of low ICE, low pain, low pain management procedures, high infant care, and high pain procedure. And you can see that there's a difference with preterm having better attention, better reflexes, and also better development. They looked at the physico-emotional component, and the high ICC, so the high infant care centers, had a better, the infants that were in the NICUs with high infant-centered care had a higher physico-emotional component, was much higher in the infants with that were coming from high ICC NICUs, and it was comparable to just normal third infants. Development and care experience is important for brain maturation, indicating the importance of developmental care for the newborn. And there's several psychologists and pediatricians that have looked at that, of the sensory motor stage development and the integration of neuropsychology. From Geneva, Jean Piaget. He said that the mental processes result from biological maturation and from the environment. Henri Vallon developed a dialectic model of concepts such as emotion, behavior, and social skills. This is in the children, in the newborn. René Spitz, which actually was the only pediatrician of the four, realized that unbalanced development during the first year of life due to unfavorable condition lead to psychosomatic troubles. And Donald Winnicott put out the concept of holding environment, and the capacity, because that was a nice review done by Pierre Kuhn in French, but actually all the sensorial system are here, so this is the touch is present, is complete at 20 weeks, nociception also 20 weeks, vestibular function is present very early, 40 weeks, gustation, taste, 14 weeks, 18 to 20 weeks, olfaction is also present, here, between 11 and 14 weeks, 24 to 26 weeks. So the baby you have in the NICU actually are able to see, to smell, to relation. So NICU is an environment that puts the preterm infant at risk of altered development, in terms of physical development, of course, but also in terms of sensory motor development, cognitive development, psychological development, and relational development. And at enhancing adapted behavior, we have to reduce nociceptive and yesterday. So light, day-night cycle, noise, alarms, manipulation, painful procedure, you have to be careful. And you need a care program centered on the developmental capacity of the child with positioning, movement, regrouping, non-nutritive suction, and non-painful adapted sensory stimulation. This approach is individualized care. It needs to be adapted to the developmental level and capacity of each child, allowing him to establish an individual recommendation in relation with care organization and adaptation to the environment used by the caregivers, and it reinforces also the role of parents in supporting the development of their infant. Sustaining the sensory tonic regulation, respect the vigilant state of the baby, postural sustain, sensorial solicitation, and this should be an uninterrupted dialogue between the baby and the adults, parents or caregivers. Individualized care, and actually I think, the sensory motor scale helps you to have a coherence and care between the shifts, because a nurse that did the scale in the morning, for example, can tell to the next shift, be careful, this children has a lot of demonstrations, behaving very good, so you can, like that, continue your care in a coherent manner. It's individualized care because you do a scale for each baby, and you know exactly what this baby needs, and it could be completely different from the one that is in the next bed. You have to reduce the stimulation, sustain spontaneous activity of the child, sustain the self-regulating activity, sustain parents as resource. The role of parents is of course important. They are holding their babies in a large meaning, physically, emotionally, and also bonding with him. Developmental care, and these, there's a Cochrane database systematic review, which decreased respiratory support, decreased length and cost of hospital stay, and improved neurodevelopment outcome at 24 months of corrected age. This is an example that was done with NEATCAP. NEATCAP is a developmental care technique, a bit different from the one we showed you, but very similar actually. And what these looked at here is the salivary level of cortisol during ROP. Induces functional brain connectivity in different networks, in the silence network, which are the networks important for actually executive function and higher function of the brain, in the sensory regions, and also in high cognitive function regions. So that was just 3 times a day, 20 minutes of music. The music was specially made by a musician, a Swiss musician, that came into the NICU and that tested a range of instruments. And he found out that the harp, the triangle, il y a du triangle dedans. Ouais. Triangle and the flute with these 3 instruments. There has been recently in 2019 evidence-based best practice guideline recommendation for developmental care. I won't go. There is parents and infant separation, the sensory environment, sleep, feeding, skin to skin, pain, stress should be avoided or reduced. Caregiving, continue to in caregiving, as I told you just before. Positioning, education and training of the caregivers, but also of the parents. So there's a lot, it's a big article with tables and what should be done and with scientific evidence. So the other thing is early intervention programs, because of course we do care during the NICU, but what happens when they go home? And there's a Cochrane database reviews. So early intervention programs for preterm infants have positive influence on cognitive and motor outcomes during infancy, with cognitive benefits persisting into preschool age. But there is still heterogeneity between the studies because the early intervention programs were still quite different. So it was a comparison that was limited, and further research is needed to determine which early developmental intervention are most effective for improving cognitive and motor outcome once the baby is out in the NICU at home. And there's still a lot of research going on that. There's some hospitals that also have put some early intervention programs where they go regularly at the parents' home to see what are the needs and to improve the development of the baby. That all interact in a program manner. Any intrinsic or extrinsic event that will alter one process will actually disrupt the overall program and alter brain development. And developmental care is about supporting the normal program for brain development in an altered environment for the baby. So you heard that already. Child is the actor, the parents are the partners, and the healthcare provider need to guide the care of the baby. And thank you for your attention. I'm happy to answer
of antenatal steroid exposure. So recently we have also come across some evidence that suggests that even let's say antenatal steroid exposure in even the late preterm babies is associated with cognitive decline when assessed at around 18 to 22 months of age. But however, we also have to balance the risks against the benefits of the steroid. So has there been any, like as per your experience or the latest research, we might not be fully aware, so has there been any shift in the use of antenatal as well as the postnatal steroids, especially in babies who are developing BPD? So what is your take on the use of steroids in antenatal and in the postnatal period?
It's been actually quite a long time ago, probably 15 or 20 years ago, this evidence that babies that were receiving some kinds of steroids, not all of them, had developmental delay and smaller brain volume measured on MRI and things like that. The problem is which steroids you use. And I just have a loss of memory. Vous utilisez quoi, de l'Adexa ou de l'Adexa? And it was probably not the hydrocortisone itself, but the adjuvant that was in the hydrocortisone. So, and as you said, I think nobody will say don't give dexamethasone to the mother if there is a preterm risk of birth. It's better to have a long maturation and a baby that breathes and doesn't have a membrane disease at birth and doesn't need a ventilator, because being on a ventilator, having breathing problems, bad saturation is also stress and bad for the brain. So the balance is quite easy actually. You have to give dexamethasone to the mothers. For the BPD infants, it's actually similar. Because you have to cure these lungs and you can, it's still breathing oxygenation is important for the brain, so you just also have to treat. But I don't know here how much babies receive dexamethasone for BPD, but in Geneva we have less and less. More CPAP than intubation and ventilation. And we have less and less babies that are really in severe respiratory distress because of the maturation that we can do early on.
Answers your queries. And here we have another question.
Thank you, Professor Stephane sir, for highlighting the difficult concepts of developmental supported care and simplifying the graphs, and it was a very difficult concept to capture. Yeah, does the preterm brain has more neuroplasticity to get better than the term brain?
It's a good question. Microstructure, function, sulcation, cortex of the thickness is actually comparing preterm infant at term to normal term infants using a magnetic resonance imaging. So they don't have the same brain at term, that's for sure. But that doesn't mean that in 2, 3, or 4, or 5 years they will not function differently. We just have this picture, which is a one-time picture. But when we follow these children in follow-up programs, they, for most of the development scale and things we look at, they actually recover and follow their normal development, even if they have at the beginning a brain that is a bit different. So there's some plasticity, reorganization, and this is due to the stimulation that mainly the parents give at home. And the only thing that we see is actually, and this is something now that is difficult. A few years ago we were doing outcome studies at 2 years, and now we don't see differences when we do, for example, early intervention. But if you go later, 5, 7, 8 years, so school age, we see more and more preterm children that have attention deficit disorders, so higher cognition problems, math problems, all the dyslexia, dysarithmetic, and things like that. So we shifted to simple cognitive and motor problems to higher function differences in the preterm infant. And that makes neurodevelopmental studies much more difficult, because it's difficult to keep your babies, your children, and see them at 7, 5 years away.
Intervention. So we also have a physiotherapist in our hospital who is trained in early intervention. So we were also trying to incorporate her in our team for developmental supportive care. And then I was really I already want any recommendation or any time frame we could follow. Let's say some baby are really hypotomic, especially the asphyxiated babies, and some babies they develop some spasticity. So while they are still in the unit, sick babies, so how early can we start with the early intervention, especially for the motor part of the developmental domain? Thank you.
Physiotherapy intervention does not destabilize the baby in terms of physiological parameters. So yeah, you can start. If you have someone that is trained to support motor development and not classical physiotherapy for a broken arm, so really baby's development, you can start as soon as it is possible for the baby. Again, it shouldn't be an intervention that destabilizes the baby. It really has to be an intervention that supports it.
What gestation age have you seen a baby who has grown into completely normal? Like, what is the youngest that you have seen?
You saw it yesterday, the 23-weekers with a full list of complications, several surgeries, and she, as a young adolescent, she's doing well. She had a lot of early intervention with Mireille, with her mother, which we taught. That's just one example, but there's some others.
So now we have a small session for rejuvenation. We have a talk from our own very beloved Dr. Lokraj sir, but before that we have a small session of meditation, a kind of rejuvenation session. So I would like to request you all to kindly close your eyes. Please be honest. I have one No cheating. I can see some of the eyes open. I have one. I hope everyone, Lisa, please close your eyes. Now try to remember the best moments of your life. Best moments. It could be the time when you got married. It could be the time when you got your first baby. It could be the time when you got some prize from some appreciation. Try to remember your most favorite person. Most favorite person. It could be your child. It could be your parents. It could be your grandparents. Try to embrace that person. Try to hug that person in your closed eyes. Feeling good, right? Keep the eyes closed. So you can now open the eyes. So this balloon sound, this blast was intentionally done just to make you realize that how our newborns feel inside their ICU. Balloon padkeda ramro feel bhayo ki naramro? How did you feel when this balloon got burst? Suddenly you were in a state of euphoria, and then suddenly we brought you down to the ground reality, right? Our newborns are exactly live in the same space. So for their brain to grow properly, they need to have longer durations of sleep. At least 18 to 20 hours of sleep also, they are constantly sleeping. So if somehow we disturb these newborns, their brain growth is directly hampered. They have bad experiences. So imagine a newborn and who is inside the NICU, and then there are so many sounds from the bell, from the gate, during our rounds, from the ventilator, from the incubator alarms. So please try to address that and reduce the noise as much as possible, so that our newborns grow into completely normal age adults. Okay. त्यति कुरा मात्र हाइलाइट गर्नलाई यो बलुन पड्काएको थिएँ. मेरो अलिकति टेक्निकल ग्लिच भएर राम्ररी पड्केन होला.
And self-consciousness, we actually, Dr. Rossi Jelidi in Geneva has actually conducted studies where she takes all preterm infants that are pre-adult, self-consciousness and meditation, mindfulness sessions, and actually these adolescents at the end, and they were actually these adolescents had better response to stress after these self-consciousness time. So interesting. Another developmental care much later on that they can do themselves.
Who has stayed with us for a long time. उहाँले हामीसँग आफ्नो MBBS, MD, DM सबै नै BPKIHS मै बिताउनु भएको छ. So there are many children who are even at the age of getting married, who he has seen in his MBBS years. त्यस्तो बच्चाहरू पनि छन् क्या. So Dr. Lokraj has been with us for a long time, and apart from the tireless effort of our whole team to make this program successful, I would like to give a special mention to our beloved sir, that he has put so much effort to make this program successful so far. And I would like to give the mic to Dr. Lokraj sir. Please, let's give a huge round of applause for him.
Introduction and descriptions of mine. Thank you, everybody. So here we go with the topic, the DC teaching, the development care teaching that can be proposed to other part of Nepal, especially in the newborn units. Babies, tiny babies, they grow into an adolescence, infancy, and then what is the status of brain? And previously, just before this, Professor Stephane also showed so many evidences. So I will continue with the same, with a brief introduction about development care. Basically, it is a individualized care, and in a nutshell, I would like to say that it provides adequate support in developing brain through adapted care, through positioning, KMC, kangaroo mother care, and family-centered care. So when parents are involved, during care. That has an added benefit, and overall it has a great advantage for the baby for the future nurture. What are the ventilation, oxygen needs, and it improves weight gain. Kangaroo mother care, we have been practicing so long. When it is used in NICU, we have seen a better outcome, and it has also been evidenced by so many scientific researches. It has improved neurodevelopmental outcome of preterm infants in relation to their stress response and has got better brain maturation. So, how this evidence come into play? If we teach somebody that baby, it should be in a structured way. If we don't do something in a structured way in a following protocol, that is not going to help a newborn. Anybody can handle a newborn, but not everybody can handle or touch a baby from developmental care point of view. So that's why it has been said earlier that every touch matters. So when we touch the baby, that is developmental supportive care through sensory motor approach, and that has to be learned through, that should come through and structured training. So for that, we have gone our HOD ma'am and Dr. Prakash has illustrated how the journey has been through trainings, teachings, bedside hands-on learning to nurses and doctors at our units, and referred nurses. So far, 5 of them are with us, and they have been doing training through. So this small plant is now growing into a bigger plant, and that's why since its inception we have come through these many years till national level of development supportive care workshop. And basically I can see the involvement, participation from all across units, neonatal units all across Nepal, and that's why it still has space to grow and it will continue to grow. So why pose something, some teaching, some learning activity that should come through, that has to be based on some rationale. Okay. So in our context, when we talk about Nepal, we should talk about our own data and our own status of NICU. The rate of, and we have been talking about preterm brain development, premature babies, how their brain behaves, how their brain functions over the years, and this is the this is a very homogeneous data across the country. In any let's say research or any data set you can come across, if you can go across, you can find almost 12 to 40% of the births are preterm. Everybody talks about the pre-ICU or newborn units and how they have been followed, how their brain, how their development, how their physical domain has turned into. So nobody talks about those morbidities later on. This graph you can find anywhere that there is a significant reduction of neonatal mortality over years, and that's why we say that there is a steady improvement in neonatal care. But what is the type of, but their development domain and the baby who have been cared in NICU, whether they have been taken care with dignity and compassion or not, that has never been taught and it has never been documented. So contextually, we have high burden of preterm delivery, as we have already said. There are limited, and we are lucky to be the first NICU in Nepal. For almost a decade, we have been practicing this, and it has been propagated to another center recently. But still, we lack these kind of developmental interventions in so many other NICU, and almost major chunk of NICUs in Nepal. Basically, it needs low cost or evidence-based strategy, and it's low cost. It doesn't cost much. We don't need sophisticated machines. We don't need extra equipment to take care of the baby or to provide developmental intervention. At the cost of challenges, we have been thriving. So in Nepal, aware of this, from grassroots level to policymakers, so everybody knows what are the challenges, and I want to highlight some of them where there are limited resources. It is well known. Overcrowding, obviously there are few NICUs were structured and really taking care of newborn as per the protocols. But what I see is inconsistent in training, because when we get trained, we change our attitude. At least once when we get trained here only, if somebody is participating for the first time, some percentage of attitude will be changed when you go back to your units. But it needs repeated training, it needs repeated intervention, it needs repeated exposure to change your attitude. Whatever we have been practicing to take care of newborn will not change in a day or just with one training, but rather it takes more and more training. So that's why I have highlighted this. And parental separation, cultural barriers are obviously there, because we have it's a vast difference across the country from geography and culture point of view. So that's why there are cultural barriers. Obviously, we have to respect the cultural barriers, but parental separation should not be followed up. It should be homogeneous, harmonious everywhere. Every NICU should practice no parental separations when the baby is born. There are so many units in our country. We see as soon as the baby is delivered, they are taken to NICUs for no reason, just to observe for a day. So that should not be practiced. Can be taken to other part, and what basically we need is a team, and what that team will do. So basically here we can see we are a team, and gradually over time takes time, and obviously it's going to change the attitude and practice to take care of newborn in NICUs. Or go to other centers, it has to be in local language. Obviously, but we have some posters here you can see, and it has to be culturally adapted. So we first need a DC team, development care team. What we can, their teachings which we have practiced in our unit only, and we need DC teaching protocol with illustrated pictures before and after from our own unit. So we can show how the baby has been destimulated, what are the factors that really destimulates, and what we have done, and such pictures can be imbibed or adapted. There the local language development care information for parents. We have just this year we have started to have on walls of NICUs, and you can see here also. So that was for stimulation. So how baby are they have been on the pictures and written in Nepali language here. So all the pictures have some captions here at the bottom, and it's a summary of all the components of development care. Basically, we have been doing in our NICU, or we have been discussing here also, and what should we do and what are the advantages of that. So it has all the advantages are long term as well as short term. So what we do to avoid the damages, if we avoid that things which damage hearing, which damage vision, which damage other part of the domain, developmental domain, that will have developmental effect later on in their life. We cannot measure, we haven't measured so far, but it is measurable, and evidence has already shown those advantages. Training and education program for staff. This one is very, very important from our part of world, that policy support from health authorities, because it is not a job for a team, one team, or for single time. It has to be repeated, and it has to be grown. It has to go to so many health facilities, and it is only possible after the health authorities and they follow the policy, or they accept the policy and they imbibe the policy in health policy. After that, when we train somebody, development care has been given, and whether exactly what been taught they are practicing or not. So just before and after, evaluation system has to be there to monitor how the development care training has done a good job. So with concluding this, development care is essential for preemie baby, can make a big impact in terms of differences. Support policies for development care across all the health system, it has to be collaborated among, and partners, families should be the partner to empower this program, development care program. When we imbibe, when we adapt that development care support program, there has to be daily sensory motor care schedule, which should be integrated in routine NICU care. That before we when we take care of the newborn routinely, there the value of SM skills. So you must have learned the same value of SM skills. That has to be filled up before and after, and that again itself monitors how effective has been development care. Parent involvement protocols, obviously it has to be there. We have changed, we have seen the changes in our NICU itself. Before without parents, now with parents, with KMC and all. So we are the one who have witnessed the change itself. And DC care should not, it's not an intervention alone, but it's a philosophy that infants' brain, body and bonding needs from the very beginning. So what we want from this to well-positioned baby. So this is the baby, this is a picture of NICU who had seizures basically. So was seizing, and that's why it has, the baby has got such posture. So there is tonic extension of right limb, you can see, and basically this is a baby who has been calm, soothed and well positioned. So the purpose of development care has to be this kind of picture, and it comes through proper training, proper learning and proper observations. Okay, so you can see about. And we have one success story that her name is Christmas. And just we got the pictures today only. And she was born 28 weeks, 1265 gram, and by just facial expression we can see the anxiety of mother and how apprehensive she is, how delicately she is taking care of baby, and I think she must be very afraid to, very apprehensive to feed the baby as well. So you can see something that can come from the facial expression as well. And this is almost 1 to 2 months after, but she had stayed almost 3 to 4 weeks I think in NICU, 4 weeks in NICU, and have been discharged. It was pre-COVID baby at 5 to 6 months of age. And just we had two pictures, one when she was 6, and she got Student of Year award this year. So she's the same. And fortunately we had the same kind of picture playing music as Mireille had shown yesterday. So can you play this? I think we just... So luckily we got the same kind of photos and videos. She's saying that how I will dance, and then she is very well known and very close to me as well, because she keeps on coming for follow-up. And only thing I have seen tonsilopharyngitis, the only thing is that. She must be at school, or she must be getting infections from other. Else, I haven't seen any language deficit or deficit in her studies. As we can ask her, we talked to her parents as well. So only thing, she keeps on coming with repeated infections only, tonsil pharyngitis. Else, I haven't observed anything deficit so far. She's 6 years old right now. Thank you. Any questions? I forgot to ask.
Skill stations, and there's also the feedback link that you might have got. So please fill the feedback for yesterday's session, and today also you will get the link. You'll get a similar link about today's program also. So please fill up the feedback form. So it will help us to know about your response and maybe improve what things we should improve for next time. So please fill the link, feedback link, and yeah. So more participation from your side, and our trainers will observe your skills. And so just like yesterday, A and B this inside and C and D outside, and then we'll rotate. And yeah. And in between the sessions, we'll have 5 minutes break so that we'll have a little bit of rest in between. Okay. So and in the meantime, I would also like to request again those who have not yet filled the feedback form. You have already got the link.
कसले गर्न रेडी हुनुहुन्छ इन्डिभिजुअली हाम्रो डक्टर एन्जिला
20 मिनट्सको सेसन गर्छ
20 मिनट्सको सेसन ल ओके ल बेबी चाहिँ अहिले हामीले पोजिसनिङ गरिरहेछौँ जस्ट तपाईँहरू बस्नु छ सिचुएसन दिन्छ है त बेबी चाहिँ यो बेबी चाहिँ इन्टुबेटेड छ बेबीलाई चाहिँ फिडिङ चाहिँ भर्खर फिडिङ इनिसिएसन गर्न गइरहेको बेबीले चाहिँ क्युज दियो क्लियरली ऊ चाहिँ प्रेस भएन हामी एसिमेट्रिकल फ्लेक्सन वर्ड गर्नुपर्छ उहाँको यो सपोर्ट छ नि त होइन उहाँको यो सपोर्ट राख्दाखेरि सपोर्टिङ फ्याक्टर त उहाँले गर्नुभएको छ नि त यु क्यान डु सपोर्टिङ तपाईँले एकछिन यहाँ गरिसकेर तपाईँले पोजिसन मिलाउँदा भयो किनभने उसको सपोर्टिङ फ्याक्टर त अलरेडी एउटा सपोर्ट गर्ने त छ नि त तपाईँले पोजिसन मात्रै मिलाउनु तपाईँले सपोर्ट गरिसक्नु पर्दैन
And maybe the respect, the order of the mother or the and now, what is the stimulation you see? Baby wasn't comfortable. Baby was crying.
face also looks discomfort. Face is expressing.
Yes, yes. And what do you think about this position?
This is सकिसकेपछि बिस्तारै छोड्नुपर्छ। अब एक्लै भयो भने चाहिँ के गर्ने भन्दाखेरि त्यही हो हिजो उहाँले भने जस्तै कपडा माथिबाट कभर गरिदिएर होइन कपडा कभर गर्न सक्छु या ह्यान्ड्सहरू तल नलियोस् भनेर होइन कपडाले कभर गरेर गर्ने कोही छैन कोही पनि हुन्छ होइन त्यस्तो अवस्थामा चाहिँ है कभर गरेर हातहरू तल नलियोस् भनेर हो नि त त्यतिखेर चाहिँ गर्न सक्छौँ हामी ल अरू बेला चाहिँ कभर नगर्ने अरू बेला त हामीले यसरी नै गर्छौँ एनएसीमा पनि अहिले पनि होइन कभर गर्दाखेरि यहाँसम्म गरिन्छ यो चाहिँ आफूले यसो मुभमेन्टहरू गर्नु सक्यो नि त है भनेर कन्भर्सेसन गर्ने र स्लाइटली कभर गरेर यहाँ चाहिँ एक्सपोज गर्ने यतिखेर गर्छ मिठो चल्नु सक्छ होइन अब एकजना मदरले या आफ्नो साथीले यसरी सपोर्ट दिने होइन यो हातभन्दा नि त्यसरी क्या यो चाहिँ माथि जान्छ फिङ्गर चाहिँ यसरी माथि त्यसरी चाहिँ गर्नु पऱ्यो अनि अब यसरी बोक्नु पनि सकिन्छ यसरी गर्दाखेरि बट्टाले लानु पऱ्यो त्यो चाहिँ रेडी गरिसकेको किन भन्दाखेरि चाहिँ यो सफ्ट बनाउनु होइन अनि स्किनमा चाहिँ नहोस् कम्फर्टेबल होस् भनेर पछाडि चाहिँ हामीले बच्चालाई चाहिँ सपोर्ट गर्दै गर्दै एकदम मानेन ओरेन भन्दा मात्रै यसो उठाउँदैन कि त्यो उठाउँदाखेरि डाइरेक्ट यताबाट होइन जहिले पनि यस्तो हुन्छ ल अनि यो आलु चाहिँ यतातिर हुन्छ यो हाम्रो काम आलु चाहिँ यो नेकदेखि अलिक तल सोल्डरलाई पनि अलिकति सपोर्ट गर्नुपर्छ अहिले चाहिँ यस्तै गरिदियो भने मात्रै हुन्छ सुतिरहेको छ यो अब यसरी नै बसिरहेछ मानौँ होइन यसो गऱ्यो गफ गऱ्यो हुन्छ है तपाईँ आमा होइन सपोर्ट गर्दै हामीले चाहिँ पेल्भिक पार्टलाई चाहिँ साइडली
This is not set up, like pacifier is not allowed. Because of such reasons. In that case, can we use like steroid gauze, soaping? We have been practicing that, but is it okay if we do that? We not practice. We don't use pacifier. We don't have sucrose in the pacifier. We completely don't use pacifier. We don't like why. And if आमाले चाहिँ बोलिराख्ने तपाईँले गर्नुहुँदा अगाडि चाहिँ बच्चाले खाना खोजिरहेको छ भनेर चाहिँ भन्यो भने अब भइहाल्नु निको भएर गर्छ अब उसले रेस्पोन्स देखायो एक्टिभ छ
No, he wants to breastfeed.
रेस्पोन्स चाहिँ
लगाउँ ल सबै पारिसके केही छ त कन्फ्युजन तपाईँहरूले मेन भनेको त हामीले चाहिँ अब जहिले पनि केयर गरेर चेन्ज गर्ने स्कुलिङ गर्ने चियाउली युजली चियाउली हो तर अब निरन्छ बिचमा अब 3 घन्टामै हो भनेर पर्खिँदा हुँदैन त्यस्तो बेला चाहिँ होइन जेनरल चाहिँ चियाउली हामी हेर्छौँ होइन हेर्न ओरेन सुतिरहेछ भने तर बिचमा अब गरेको छ
हामीले गरेर 2 घन्टा या 3 घन्टामा दुध खुवाउन भन्नुहुन्छ
लाइफ स्लिप याद गर्नु
आइडियल भनेपछि बेस्ट डिप स्लिपमा भएको पर्छ तपाईँले भनिन्छ कतिखेर हुन्छ भने हाइपोग्लाइसिया भइदिएलाई टाइममा यसलाई जति खानु पर्ने त्यो कम्प्लिकेट चाहिँ भएर लामो क्याप्सन 3 आवर्स भयो भन्दा कमसेकम 4 घन्टा बढी क्याप्सन नहोस् 2 घन्टाभन्दा कम क्याप्सन बाँकी 2 to 4 आवरमा पछाडि तर त्यो पनि डिपेन्ड गर्छ अलिक ठुलो बच्चा छ 2-3 महिना भइसकेको छ भने 4 घन्टा 5 घन्टा टोरेट गर्न सक्छ सानो फ्रिडम छ भने 3 घन्टा पनि टोरेट गर्न 6 घन्टा गर्न सक्छ त्यो पनि इन्डिभिजुअलाइज गर्नुपर्छ जेनरल न्यू बोर्न जेनरल टर्म युनिटलाई चाहिँ 2 to 4 आवर्सको रेन्ज
त्यस्तो बेलामा त एक्लै हुँदा त अलिकति छेउमा ल्याउने अनि त्यसपछि यो सब ट्रेनिङहरू गर्छ आफूले चाहिने हामीले यो यसलाई चाहिँ टच गराउने
पातलो भन्छ गाह्रो
अहिले नजिकै लिएर अब सबैले बम्पिङ सुरु गर्दा भयो डक्ला खाएर भुँडी लगाउँ हुन्छ अरू केही गर्नुहुन्छ हामी चेन्ज गरेर अझ यो वाइफ्सहरू चिसो छोडेर पहिला पहिला चिसो हुन्थ्यो होइन अलिकति पर्सन लोड्ने जस्तो हुन्थ्यो क्या हामी चाहिँ वार्मको तल राख्ने रहेछ राख्ने होइन भने चाहिँ अब कटन निकालेर के यो अहिले यतिकै राख्नु वार्मको तल यो यतिकै हुन्छ यो यतिकै हुन्छ वार्मको तल भएपछि वार्मको गरेको छ भने चाहिँ अप्पर टु डाउन गर्ने गर्दै लाने भने चाहिँ स्टुडेन्ट यताउति लाग्दैन पनि होइन यही लगाइदिनु यही लगाइदिनु किनभने त्यो सानो छ नि त यसरी गर्नु सक्छ
स्क्विज गर्नुको लागि
अगाडि चाहिँ अगाडि नै यो त स्क्विज अब यस्तो गर्नु पर्यो अगाडि चाहिँ त्यस्तो बेला हामीले चाहिँ चलाएर इन्सिडेन्ट भयो होइन त्यो भने एक्सटेन्डेड सर्जन लेगहरू होइन प्यानिङ फुडहरू गर्ने हुन्छ त्यस्तो बेला चाहिँ के गर्ने भन्दाखेरि हामीले छोड्दै राम्रो ट्याक्टर स्टिलेसन जो हुन्छ नि हङ्ग्री पिरियड गर्नु यसो टच गर्ने होइन त्यो भनेको त्यसलाई गराएको जस्तै हो नि केटामा चाहिँ हामीले चाहिँ मलाई हुँदै छु है भन्ने हाम्रो चाहिँ फिल गराउनु पऱ्यो क्या यसमा चाहिँ सेफ फिल गराउनु पऱ्यो है
For the same rating, like today he might have a lower score than tomorrow he might have a better score.
Would you please excuse our English? We will be our best. As a new member of this wonderful team, I would like to express my gratitude for the welcome I received. Since my arrival, I have observed the unwavering motivation of the Developmental Care MU,
in collaboration with Professor Bulangi, has been exported to the other side of the world, where we have found in you professionals who listen to babies, know how to observe their abilities and provide support during difficult times. The pride we feel today is intense, and we could not have dreamed of better ambassador to carry the message we have conveyed to you. Now, it's up to you to bring to Nepal and in neighboring countries this philosophy, which make the child an active participant and is in their own development, parents as partner and you as guide.
Manager is that the nurse supports baby and their family, and that the doctor and nursing staff also support their team for the best, as well as through the difficulty inherent in any change. Without your support, the developmental care could take a backseat during emergency. Developmental care is a form of care in its own right and is part of your professional ethics. I'm proud of you, and I'm certain that you will continue to work miracles. I would also like to thank Professor Sizonenko for taking us on this humanitarian adventure, where we have become the Swiss family. Thank you all.
A gift for the briefness with Nisha and Lokraj and Stephane.
14, which it was my first visit in BPKIHS, how they are today and what would be the future, I hope. So 2014, that's what we saw for our first visit. It was not at all a visit aimed at starting developmental care. I was there with the head of NICU from Geneva, and we said we have to start developmental care, which was looked like an easy task because it's not that expensive. It's just changing habits. You don't need a lot of money to buy ventilators or what's on, but actually it was a bit more challenging than I thought. but really happy where we are now and how the team here has embraced developmental care. So we started with teaching. First workshop was in 2016, and then there has been twice a year we were coming. I would even say of mine. I'll just show you this video, which is 2.5 minutes. This is what we saw the first time. It makes you laugh now. Same baby. So I think this short video will actually summarize all the path that has been and the work that has been done to improve baby's care. In 2019, 23 and 24 there was actually 7 nurses that were certified. 2 have left for other reasons. And we still have 5 here, and that was a good achievement. These 5 nurses have, well, so 5 nurses are really involved in now teaching, supporting developmental care in the unit to the new nurses, but also on a daily basis. But they are also involved in being trained to teach to others. So since 2023, they come with us to TUTH, so they get exposure and they actually are on the first or the front field of the teaching, and we are behind supporting them. At the top of the mountain, 2 days and these 2 days of a workshop. We've been dreaming with Nisha since about 2 years or something. It finally happened, and I must say I'm very proud of these 2 days. I think the presentation were all amazing, very good. We all felt that you get into yourself, into your professional daily work, the nurses, but also the doctors, and I'm very happy about that also, that it happens. And I think this has been achieved because there's 2 persons that really pushed that behind is Professor Nisha and Professor Lokraj, and I'm very thankful. They were always supportive, pushing ahead behind us and behind their team to really achieve where they are today. But I hope it's not finished for them, that there's a future, and the future is maybe that, I hope, having people from the BPK, not a specific target, but going all around the country, and why not, I don't know who said abroad, but why not in India, the region around. I actually met a neonatologist from Bhutan in TUTH, which was very interested, so that would be also a place to go. But I will come with you if you go to Bhutan. So yes, that's your next step. You have achieved a lot. It's just a new beginning. You're going to write a new chapter of developmental care in Nepal. And I believe in you, I trust in you, and if needed, we'll always be behind you, to support you also. I have to thank many people, pediatric, Professor Nisha, Professor Rupa, which was here at the beginning and also was really believing in this workshop and improvement of care, Professor Lokraj, also the nursing faculty, Professor Ramananda, Professor Basanta, Professor Upanda. I think Upanda, Professor Upanda was here the first day, if I'm right, I haven't seen the others. I think the sisters in charge of NICU and Jamuna at the beginning, Mina, Anita and Susma also have supported greatly on this, more than anybody or your referent nurses, Shilpa, Renuka, Garima, Marshana, Tiza, and the two that have left, Rupa and Subina. I can't thank also enough the referent nurses in developmental care in Geneva, without whom that wouldn't happen basically, because I wouldn't be able to teach all what they have to teach you. Mirta at the beginning, Mireille, Valérie, Roxane and Caroline now. I would like to really thank the organizing committee of this workshop. You've done a tremendous work. Session were good, hands-on session also. I think everybody appreciated it. Thank you to the NICU, nursery and neonatal staff, nurses and doctors that were always enthusiastic about learning, about changing their practice. And I have to say thank you to the Geneva University Hospital Commission for a humanitarian project and cooperation that funded all this project, and that is also funding the one in TUTH. So, thank you very much, all of you. It's a great honor to have met you, to have worked with you. And as Mireille said, the Swiss family will be always with you. Thank you.
To come on stage and to honor Professor Stephane Sizonenko with acknowledgement and plaque of honor from the Neonatal Division, Department of Pediatrics, BPKIHS Institute of Health Sciences.
Appreciation
on development care through sensory motor approach, and may I take this honor and privilege to say some words as a word of thanks on behalf of Neonatal Division, Department of Pediatrics, BPKIHS Institute of Health Sciences. First and foremost, I would like to express my heartfelt gratitude to Professor Nisha K. Bhatta ma'am, HOD Pediatrics, Chair Neonatal Division. She has been the nudging force behind all this let's say this whole film, she is the one who is the force. So she has conceptualized this workshop. She has made this happen. She had been conceptualizing for last 2 years, and we have some problem with the dates, which month we are going to happen. She had been in contact with Professor Stephane Sizonenko, and through mails, she has been conducting where, and how it can be made happen. So, a round of applause for Professor Jelidi. Thank you everybody, and she will be keep on encouraging us for such events. Again, I would like to express my heartfelt thanks to collaborator, partner, HUD University, Geneva, Professor Stephane Sizonenko and his team, Mireille, Roxane, Caroline, and all the way his better half has been here throughout the day to encourage us as well, Dr. Nordena. So we want to express heartfelt gratitude to them as well. Your support, expertise and willingness to share your knowledge have truly elevated the quality and impact of this program. And it has been a pleasure to witness this successful collaboration between these two institutions. Thank you everybody. Different nurses from our team from Geneva. Thankful. I want to thank you for your insightful sessions and hands-on demonstrations. Your contributions have not only deepened the knowledge, understanding of sensory motor approaches in development care, but also inspired all the participants, and let's sure they will integrate these practices into their clinical as well as academic work. So they are the referent nurses, but they were instrumental, and during hands-on sessions you must have felt how they teach, how they correct and how they guide the participants. A sincere thanks to all the participants who joined us from various department institutions from all across the country. Your active engagement, curiosity and enthusiasm made this workshop vibrant and interactive. We are also grateful to the organizing team, including me. NSU nurses, in charge, both in charges, and the assistant and supervisor, where beyond the force, team residents have already mentioned their names, but it is not enough for their tireless effort and work. Dr. Prakash, who is very instrumental with his computer work, I am repeating again, Dr. Seekhar, Dr. Shah, Dr. Vichan, and all the department, all the faculty and senior residents from Department of Pediatrics, they were quite supportive towards this DC workshop to make it happen and to make it success. And to also the volunteers and technical staff behind the scenes to ensure smooth execution except some technical glitches of every aspect of this event. Lastly, we look forward to continuing this journey together, building stronger partnerships and making a lasting difference in the field of developmental care.
Well, म चाहिँ गीत गाउन भन्दा पनि एउटा सबैजनासँग फेरि हामीले भेट्ने मौका पाएका छौँ, फेरि भेट्ने मौका पायौँ र त्यो भाइब्सलाई चाहिँ अलिकति उतार्न जान लागिरहेको मात्र हो। अब मन पर्नु हुनेछ। टाढा टाढा जानु छ साथी एक फेर हाँसी छुटिसकेको मायालाई साथी एक फेर घाँसिदेऊ। Once again. journey.